Yeah, cool. Let us start the session. So first session, we have completed as much as possible. Second session also, we'll try to finish as much as possible. First, we are going to talk about the environmental emergencies. So in that, the high altitude related illness, heat related illness, and hypothermia and frostbite. These are the four important things that they tend to regularly ask in exam. So first, let us talk about the high altitude related problems. In that, the milder form of illness will be acute mountain sickness. If you have a very mild form of illness, you call it as what? Acute mountain sickness. And the only problem in acute mountain sickness will be fatigue and exercise intolerance. If they ask you what you are going to do for prevention and treatment of acute mountain sickness, it's going to be acetazolamide. Otherwise, nothing really required. So to prevent as well as treat, in exam, please answer acetazolamide, that's it. But it's more for prevention rather than therapy. Severe forms of illness is what we called as high altitude pulmonary edema and high altitude cerebral edema. Severe form of illness in the sense the patients with high altitude pulmonary edema will be having shortness of breath and hemoptysis. Shortness of breath, crepitations, and hemoptysis. Whereas in high altitude cerebral edema, patient will be having altered mental status and probably even seizures. So these are the characteristic features of severe forms of injury. In case if your patient is having severe form of injury, the treatment of choice will be immediate descent or rapid descent. Come down as soon as possible. If you can't descend immediately, then we have portable hyperbaric brags. Along with that, you can try something called as dexamethasone. Dexamethasone can be tried if you want. In case if you have, you can try oxygen, or you can try nifedipine, or you can try even CPAP. In case if it's a high altitude pulmonary edema. Yeah, I've shown in my regular classes now what are the portable hyperbaric bags. These are called gamma bags, right? So if immediate descent is not possible, then you can use portable hyperbaric bags. Otherwise, mostly we are going to stick on to descent and dexamethasone only. If it's a high altitude pulmonary edema, then oxygen, nifedipine, CPAP will be useful. Otherwise, not. So what about heat exhaustion and heat stroke? As I told you, heat exhaustion is a milder form of illness. Heat stroke is a severe form of illness. What is the big difference? Heat stroke patients will have core body temperature of more than 40.5 degrees Celsius. And these patients will be having, these patients will be having hypotension and low GCS. And more importantly, these patients will not have sweating. Sweating will be lost. But in heat exhaustion, temperature will be less than 40.5 degrees Celsius. Vitals will be normal otherwise. BP, GCS will be normal. And patients will be sweating. Sweating will be intact in heat exhaustion. In exam, usually they will be asking only about the treatment of heat stroke, not heat exhaustion. Heat exhaustion can be just treated with hydration and passive cooling. But heat stroke, treatment of choice will be rapid cooling. You have to rapidly cool the patient. And for that, we can use passive cooling. And we have something called active cooling. Active cooling, we have external cooling and we have internal cooling. So external cooling means we have ice water, sponges, tepid sponging. Okay, so you can do whatever you want. Some fans you can keep with which blows cold air. And internal cooling can be done with cold IV fluids. Cold IV fluids which are chilled to approximately 15 degrees Celsius. Correct. Normal saline or ringer lactate. Cold IV fluids can be given. Passive means just keep patient in a shaded place. That's all. The question is when to stop active cooling. When to stop? There are two indications. I told you, right? Once the patient starts shivering and the temperature becomes less than 102 degrees Fahrenheit. These are the two indications to stop active cooling. And coming to hypothermia, mild, they won't ask in exam. Usually moderate and severe only they will ask. So during moderate hypothermia, what happens? There are certain, temperature-wise, if you ask me, mild is 35 degrees Celsius, moderate is less than 32 degrees Celsius, and severe is less than 24 degrees Celsius. Usually they will ask about mild, moderate, and severe only. If it's a moderate hypothermia, patient's BP will drop, heart rate will drop, and patient will start developing low GCS, altered mental status, and this can lead to something called paradoxical undressing, right? This can lead to something called paradoxical undressing. And apart from that, patients can develop ECG and EEG changes. ECG and EEG changes. You know what are the characteristic ECG changes, right? So here is the typical ECG in a patient with hypothermia. Two important points. One is they are going to develop these J waves. These are the characteristic J waves that occur in setting of hypothermia. These waves are also called as Osborn waves, right? These waves are also called as Osborn waves. And patients also will be having long QT. One of the important causes of prolonged QT interval is J waves. U waves will be coming after the T wave, man. U waves will come after this thing. J waves are close to the QRS complex, right? How can you confuse U wave with J waves? They come at a completely different location. So these are J waves, and patients also tend to have prolonged QT interval. Okay, long QT interval. All right. So these are the characteristic ECG changes. If the patient is having severe hypothermia, usually they will be in coma, and usually they will go for cardiac arrest, and they will develop ventricular arrhythmias like ventricular tachycardia and ventricular fibrillation. So this is the characteristic feature of severe hypothermia. In moderate to severe cases, you have to definitely rewarm the patient. Correct. So rewarming will be the treatment of choice. So rewarming rate should be at least 0.5 to 2 degree Celsius per hour. So this is the ideal rewarming rate. Rewarming should be occurring at a rate of approximately 0.5 to 2 degree Celsius per hour. And rewarming, as usual, as we discussed, it can be passive rewarming, just giving blankets to them, or it can be active rewarming. Active rewarming. Again, as usual, we have active internal rewarming and active external rewarming. Best example of external rewarming will be placing heaters near them and giving warming blankets. Giving warming blankets to them. If you talk about internal rewarming usually will be done with lavage. Internal lavage. Classically, guidelines recommend you to do thoracic lavage. You can do peritoneal lavage also, but you can do thoracic lavage. Yes, the temperature of the solution will be approximately 44 degree Celsius. That is internal lavage, thoracic lavage, by putting a chest drain, insert chest drain on both sides and do lavage. So that is treatment of hypothermia. Frostbite, you all know, the only symptom that the patient is going to complain is numbness, and mostly it's going to occur in toes and fingers. Whatever parts is exposed, that's the usual place where the frostbite occurs. And most of the patients at the time of presentation will complain only of numbness. If you suspect immediately, you have to start with rewarming. Rewarming, and the ideal temperature of rewarming solution is 37 to 40 degrees Celsius. We know. That's the approximate temperature of the rewarming solution. And once you, during rewarming, you have to always add analgesics because this is a very, very painful condition. So especially opioids should be added. NSAIDs are contraindicated. Opioids are the ones should be added, and it's an excruciatingly painful condition. That's correct during rewarming. So you have to definitely add analgesics, and then decide on whether the patient is presenting within 24 hours or after 24 hours. If they present within 24 hours, you can do MRA to decide on RTPA, alteplase, whether it can be given or not. If there is severe thrombosis, you can give alteplase, otherwise no. If the patient is presenting beyond 24 hours, then you can do bone scans to determine whether how much you have to amputate. The extent of amputation can be determined with the help of bone scan. So if they ask you the tracer that is used in bone scan, it is technetium 19 MDP, methylene diphosphate, MDP. So this is the tracer that is used in bone scans generally. Yeah, that somehow completes our environmental emergencies. Then coming to pulmonary vascular problems. In pulmonary vascular problems, there are two things we need to discuss. One is venous thromboembolism, and second is pulmonary hypertension. Venous thromboembolism means we are going to only talk about deep vein thrombosis and pulmonary embolism. So we all know the risk factors follow virtuous triad. What is virtuous triad? We have discussed so many times: endothelial injury, hypercoagulability, and venous stasis. Correct? So what are the risk factors? Immobilization. How much immobilization? At least 3 days in the last 3 months. That's called rule of three, right? More than 3 days in the last 3 months. And second important and crucial risk factor is hormonal changes. Hormonal changes in the sense you talk about pregnancy, early postpartum period, OCPs, SERMs, hormone replacement therapy, anything. And malignancies, of course, can cause venous thromboembolism. And thrombophilias are there, like factor V Leiden mutation and antiphospholipid syndrome. We discussed so many times that the most common inherited thrombophilia is factor V Leiden mutation. The most common acquired thrombophilia is antiphospholipid syndrome. So thrombophilias, yeah, that's correct, thrombophilias. Then we can also think about surgeries, major surgery, especially lower limb orthopedic surgeries. Any major surgery has a risk of venous thromboembolism, but the lower limb orthopedic surgeries carry extremely high risk of venous thromboembolism, especially hip arthroplasty. Very, very high risk. So you have to give prophylaxis accordingly. So if they talk about upper limb DVT, usually it will be due to central venous catheter. Some small extra point that you can note. Usually it will be due to chemoports and central venous catheters. That's the usual reason for upper limb DVT. And how the patient will present. In case if you are thinking of a DVT, the most important finding will be asymmetric calf swelling, tenderness, and edema. Asymmetric calf swelling, pain, and edema. And there will be superficial erythema also in most patients. This is a characteristic finding. If the patient is having pulmonary embolism, then most important presenting finding will be unexplained shortness of breath. We discussed so many times. Otherwise, there will not be any clinical signs at all. Only shortness of breath will be there. And if you do ABG, and you will see type 1 respiratory failure because of VQ mismatch, poor perfusion. Type 1 respiratory failure. And if you do ECG, you will see sinus tachycardia, the most common change. Right axis deviation can be seen. Right bundle branch block can be seen. And RV strain will be there. T wave inversion in V1 to V4 may be there. And there is a very important finding called as S1Q3T3 pattern. Once upon a time, it was considered to be very specific. Nowadays, it's pulmonary embolism. In echocardiogram, you see something called RV dysfunction. That's kind of more common in echocardiogram. That's what I'm going to see. And in X-ray, X-ray is not very useful. There are many signs. For example, you have Hampton's hump, you have Westermarck sign, and you have Pallas sign. Westermarck sign, and you have something called Pallas sign. There are 3 important signs, right? So these are the 4 important investigations that we do, right? So let us have a look at the ECG in a patient with pulmonary embolism. So in ECG, you can see sinus tachycardia, but even though it's the most common entity, but sinus tachycardia is not always seen, even though it's the most common. This is an example of an ECG which doesn't have sinus tachycardia. Sir, speak bit slower, can't understand. Am I going too fast? I think it's a revision session. No? For a revision session, it's fine, right? Because if I go very slow now, then we'll not be able to revise at all. We'll not be able to complete, right? What is F9? I use MacBook, man. I don't know what is F9. Okay, F9 is fine. Okay. Okay, fine. Let us start. Okay, cool. Let's continue. So what are the findings you will see? You will see right bundle branch block, right? If you see in V1, you're having right bundle branch block. I told you whenever you have a white QRS with positive QRS, that is right bundle branch block. And you're also seeing right axis deviation. You know how to find out right axis deviation? We discussed so many times. Lead 1 negative, lead A wave positive. But if this lead 1 is predominantly negative, that usually indicates a right axis deviation. And you're also having T wave inversions in V1 to V4, which is very important sign of RV dysfunction. And apart from that, you're also noticing the Q wave in lead 3 and T wave inversion in the same lead. This finding is what we called as S1 Q3 T3 pattern. S1 Q3 T3 pattern, which is also called as McGinn-White sign, which is also called as McGinn-White sign. So all the characteristic changes are seen in the CCG except for your sinus tachycardia. Everything else is there in the CCG. And here's an example of the classic Hampton's hump. It's a peripheral wedge-shaped opacity that is formed because of pulmonary infarction. Because of pulmonary infarction, there will be a peripheral wedge-shaped opacity, and this is what we call as Hampton's hump. Hampton's hump. And echo is going to show something called right ventricular dysfunction. And if you know it's a DVT or pulmonary embolism, how will you work up for DVT and pulmonary embolism? Workup is very simple. You're going to do, we are seeing the clinical probability using something called Well score. We have to see clinical probability, and this clinical probability is determined by something called as Well score. I told you so many times, you have to Google it. You have to find out the Well score for DVT, Well score for PE, and last minute, it's better to look at the parameters used in Well score and then go to exam. So if the Well score probability is low, then I'm going to do D-dimer. D-dimer, if it's normal, I can rule out pulmonary embolism. In case if the clinical probability is high or if the D-dimer levels are elevated, then I have to do imaging. Correct. Based on imaging, if it's positive, I can make a diagnosis of venous thromboembolism. If it's negative, I can basically rule out venous thromboembolism. What are the imaging options we have? Option number 1, if you are suspecting DVT, you can do compression ultrasound. If your primary suspicion is DVT, you can do something called compression ultrasound or venous Doppler, whatever you want. But what we do in practice is compression ultrasound in the emergencies. Or you can do a CTPA if the patient is having pulmonary embolism suspicion. CT pulmonary angiogram is the gold standard. They ask alternative to CT pulmonary angiogram, it's going to be VQ scan, ventilation perfusion scan, and that is only an alternative to CTPA. But the best is always CT pulmonary angiogram, the gold standard. Once you have worked out for DVT pulmonary embolism and you have found out what is the problem, start treatment. Anticoagulation is going to be the treatment of choice. Anticoagulation is the treatment of choice. In case if anticoagulation is contraindicated, if anticoagulation is failed, then you can use something called IVC filters. Otherwise, I'm not going to use IVC filters. Only indication for IVC filter will be contraindicated anticoagulation or failed anticoagulation. And what are the indications for thrombolysis? Indications for thrombolysis. Indication for thrombolysis will be only one. That is a pulmonary embolism that is unstable. The patient is having pulmonary embolism and a systolic BP of less than 90. This is the only available indication for thrombolysis. So that's an exam question. So only available indication for thrombolysis, PE, which is unstable, SBP less than 90. And commonly what we are going to use RTPA for adults, alteplase, doses 100 milligram over 2 hours as an IV infusion. Okay, so these are the indications for thrombolysis. And what anticoagulation is preferred? Remember, for admitted patients, we give heparin only. That is having no doubt. But for long-term anticoagulation, we're going to use DOACs ahead of warfarin. DOACs are preferred in this situation. Dabigatran, apixaban, edoxaban, and rivaroxaban. There are 4 DOACs. Any one of the DOACs can be preferred for long-term anticoagulation. But for short-term in the hospital, always prefer heparin. That's it. And in CTPA, this is how you're going to see the thrombus. This is how you see the thrombus as a filling defect, as a blackish area. Other areas are normal. This is where the thrombus is located. In fact, this is an example of a saddle embolism, which sits right at the bifurcation of main pulmonary artery into right and left pulmonary artery. Then we can discuss about pulmonary hypertension. We have many different types, right? So in that only the first type is what they're going to ask in exam. That is type 1 pulmonary hypertension. So we have other types. Type 2 pulmonary hypertension, type 3 pulmonary hypertension, type 4 pulmonary hypertension, and type 5 pulmonary hypertension. Yes, people are commenting that whenever you want to diagnose pulmonary hypertension, the mean arterial pressure should be more than 20 millimeters of mercury. This is the diagnostic criteria for pulmonary 20. It is pulmonary hypertension. And type 2 pulmonary hypertension is basically due to left heart disease. So treatment of hypertension is due to chronic hypoxemia, which can be due to COPD, or it can be due to interstitial lung disease, or it can be due to obstructive sleep apnea, or it can be due to even high altitude. High altitude also can cause chronic hypoxemia. So anything can cause type 3 pulmonary hypertension, typically lung problems. Type 4 pulmonary hypertension is also called as chronic thromboembolic pulmonary hypertension, CTPH. Chronic thromboembolic pulmonary hypertension. It is because of prior pulmonary embolism that has embolized and causing chronic occlusion. Type 5 is miscellaneous. It's not important. What about type 1 pulmonary hypertension? It's also called as pulmonary artery hypertension. For any pulmonary hypertension assessment, Swan-Ganz is the best. Swan-Ganz is considered to be basically the gold standard for assessing any degree of pulmonary hypertension. For diagnosing, for management, for assessing response to therapy, for everything, Swan-Ganz is the gold standard. That is your right heart catheter, or otherwise called as pulmonary artery catheter. So for type 1 pulmonary hypertension, there are two things you need to know. One is it can be related to BMPR2 mutation. Second, it can be related to CREST syndrome, that is limited scleroderma. Third, even Eisenmenger syndrome will come under type 1 pulmonary artery hypertension only. So treatment of choice for type 1 pulmonary artery hypertension will be vasodilators. So what vasodilators you are going to give? It depends on vasoreactivity testing. You're going to test something called vasoreactivity testing using either inhaled nitric oxide or IV ipoprostenol. We discussed already, the vasodilators. Same, inhaled nitric oxide or IV ipoprostenol. So use some vasodilators and test for vasoreactivity. If it's positive, then you can give dihydropyridine calcium channel blockers like nifedipine. In case if the vasoreactive testing is negative, then in that situation, it's better to see the functional class. For WHO class 2 and 3 patients, we usually start with double therapy. In case if the patient belongs to WHO class 4, or if the patients are not responding or in class 2, class 3 with dual therapy, in those patients also you can go forward, triple therapy. Dual therapy means commonly we combine ambrisentan with tadalafil. Ambrisentan with tadalafil. Tadalafil is a phosphodiesterase 5 inhibitor. Ambrisentan is a endothelin receptor antagonist. Ambrisentan with tadalafil. And if it's a triple therapy, you'll give the same dual therapy plus I'm going to add prostanoid. So we already discussed about what are the details of the prostanoids. So we have prostacyclin analogs and we have prostacyclin receptor agonists. What are the prostacyclin analogs? We have epoprostenol, treprostinil, iloprost. What are the prostacyclin receptor agonists? They are oral drug, only one drug available, that is called as Selexipag. So prostacyclin analogs is different, prostacyclin receptor agonist is different. Analogs, epoprostenol, treprostinil, iloprost. Prostacyclin receptor agonist is Selexipag. So that's how you're going to treat a patient with type 1 pulmonary artery hypertension. Next, let us move on to pleural disorders. In the pleural disorders, only few things are important. In that, one thing that is important is differentiating between a transudate and a exudate. So what are the important transudates? Whichever effusion that occurs because of RAS activated states, you can take them as transudates. Heart failure, cirrhosis, nephrotic syndrome. Okay, so these are the typical RAS activated states that cause problems, right? So in that, if they ask you most common cause of effusion in the world, it is actually heart failure. That's the most common cause. Exudate means the most common cause of exudate is parapneumonic effusion. Parapneumonic effusion, tuberculosis, malignancy, and connective tissue disorder. Malignancy and connective tissue disorder. In the connective tissue disorder, rheumatoid arthritis and SLE are more important. That too, RA is extremely important because they tend to produce very low glucose in the pleural fluid. Extremely low glucose in the pleural fluid. That's why the RA efficients are quite special. Apart from that, we have paraneumotic efficients, TB, and malignancy. TB-related efficients can be easily diagnosed by looking at adenosine deaminase levels. It will be definitely elevated. And how to differentiate between trans-red and X-red? For that, we have a criteria called as Lights criteria. We have 3 points under Lights criteria. In that, what is point number 1? You're going to compare efficient protein with serum protein. If it's going to be more than 50%, that is considered to be positive. Then you're going to compare efficient LDH with serum LDH. And if it's more than 60%, that confirms it's X-ray. Or in the third classification, third point, you need not do the serum LDH at all. If your efficient LDH is more than 2/3 of the upper limit of normal of serum LDH provided by your laboratory. Okay. If the efficient LDH is more than 2/3 of the upper limit of normal of serum LDH, that is also kind of X-rated. Any one, if it's present among the 3, it is X-rated efficient only according to Lights criteria. And here is a example of an effusion. So what are the things that you're going to see in effusion? 2 things in X-ray. One, there will be blunting of costophrenic angle. CP angle will be blunt. Second, there will be something called meniscus sign. It's actually an X-ray artifact. It's not a true meniscus. It's just an X-ray artifact. And one of the important features of pleural effusion is reduced air entry, and there will be stony dull note. Stony dull note on percussion. There will be reduced air entry on auscultation, but on percussion there will be stony dull note. So these are things that are going to confirm that you're dealing with the effusion. And what are the indications for chest drain in a paraneumotic effusion? Indication for chest drain in a paraneumotic effusion. Indications for chest drain. So indication number 1, it should be complicated. Indication number 2, it should be loculated. Or indication number 3, it should have a frank pus. When you aspirate, if you aspirate frank pus, yeah, that's going to tell you that you have to put a chest drain. So loculated, empyema, what is complicated? Complicated means the organisms have started invading the pleural space. That's what we mean by complicated effusion. So complicated means by the rule pH should be less than 7.2. Second, your gram stain of the pleural space must be positive, or culture of the pleural fluid must be positive, or more importantly, glucose less than 60. This is also very important. Third, I told you already that if the gram stain is positive or pleural fluid culture is yielding some organism positive. So these are all signs of complicated paraneumotic effusion where you definitely insert a chest drain. Very important point. Whenever it comes to pneumothorax, most of the times the question will be hovering around tension pneumothorax. It's a clinical diagnosis, tension pneumothorax. First, how will you say that the patient is having pneumothorax? Whenever there is a pneumothorax, there's going to be sudden onset chest pain. And it will be a pleuritic chest pain. Sudden onset chest pain. And it will be a pleuritic chest pain. And apart from sudden onset chest pain, many patients will be exhibiting shortness of breath. And if you examine these patients, there will be reduced air entry on the involved side, plus there will be hyperresonant note. Hyperresonant note on percussion. There will be reduced air entry on the involved side, and there will be hyperresonant note on percussion. So how will you say it's tension? Now pneumothorax component is done. Now you have to say tension, right? Tension means there should be 2 problems. Either there should be hemodynamic insult, like jugular venous distension, or hypotension. Like what is in Beck's triad, if you have jugular venous distension, and or hypotension. That itself is a sign of tension pneumothorax only. Number one. Second, it must be causing either a tracheal and or a mediastinal shift. Tracheal and or a mediastinal shift. If a solid structure if a air is able to push a solid structure, it must be tension only by default. And what is the urgent treatment for tension pneumothorax? It's going to be needle thoracostomy. Any wide bore needle available in a hospital, take the widest bore needle and insert on the chest wall. So either in the second intercostal space in the midclavicular line or fifth intercostal space in the mid-axillary line. Sorry, fifth intercostal space in the mid-axillary line. According to guidelines, yes, this area is better site for achieving a good success rate, but it depends. Whatever you want, you can follow. But according to guidelines, this is what is preferred. Needle thoracostomy, yeah, you have to then followed by insertion of chest drain. Because with needle thoracostomy, you're only converting a tension pneumothorax into a non-tension pneumothorax. But still, if you want to clear the pneumothorax completely, you have to insert a chest drain. So don't forget, it should be followed up with a chest drain. And here is the X-ray of a patient with pneumothorax. So the very idea of finding pneumothorax is to find out the border of the collapsed lung. So here is the collapsed lung border. Until that, you will be able to see all the bronchoscopal markings. But outside that, it's full of air because the pleural cavity has expanded with air. That's why there is no bronchoscopal marking in that area. And in this patient, there is pushing of the trachea to the opposite side. There is tracheal shift as well as there is mediastinal shift. You can notice that normally mediastinum should come like this, the right border. That's how the right border should be. But here the bulge is lost, which means the mediastinum itself is getting pushed to the opposite side. This is the clear-cut case of tension pneumothorax. And in M-mode ultrasound, this is not 2D ultrasound, this is M-mode ultrasound. In M-mode ultrasound, in normal individuals, you'll be able to see a sign called as seashore sign. You'll be able to see a sign called as seashore sign, where the chest wall will appear as straight line and the lung will appear as like beach. This is called seashore sign. Once the patient develops pneumothorax, seashore sign will be lost. Rather, they're going to have something called barcode sign. Why it's called barcode sign? Now, because the lung collapse, there is no lung here and everything looks like straight lines, like chest wall only. So this is what called as barcode sign, or some people call it as stratosphere sign. Stratosphere sign. Have you understood so far? Whatever I told you? Just hold on a sec. Okay, let us move on. So we're going to talk a little bit about shock now, shock and cardiac arrest. Once you finish shock and cardiac arrest, then we have only pulmonary infections, and that's all. Then after that, things are going to become easy because these are the areas that are kind of critical care and emergency medicine. It's going to be quite tough. So, for shock also, definition is very simple. Mean arterial pressure less than 65 millimeters of mercury, plus there should be evidence of tissue hypoperfusion. That is shock. Mean arterial pressure less than 65, plus there should be evidence of tissue hypoperfusion. And we have four types of shock: hypolimic, cardiogenic, distributive, and obstructive. Yeah, sorry. Hypolimic, cardiogenic, distributive, and obstructive. In the obstructive shock, we have pulmonary RV type and mechanical type. So, hypolimic shock means it will be usually due to trauma surgery. Cardiogenic shock means LV failure. Distributive shock means typically due to sepsis. An obstructive shock means if pulmonary RV type, we are talking about pulmonary embolism. RV means we are talking about right ventricular MI and right ventricular failure. Mechanical means we are talking about cardiac tamponade and tension pneumothorax. We are talking about cardiac tamponade and tension pneumothorax. Something is pressing on the heart. Okay. So the gold standard for diagnosis and treatment of any shock is Swan-Ganz again. That is right heart catheter or pulmonary artery catheter. Swan-Ganz is the gold standard for diagnosis as well as management of any shock. But in practice, we don't do that commonly because it is not that easy. So what are the things you're going to see in Swan-Ganz? Preload, pump function, afterload, and tissue perfusion. If it's a hypolimic shock, preload will be low. As expected, pump function will be low, but cardiac index will be low, but it's only in late stages. And neurogenic shock will come under distributive shock. Neurogenic shock and anaphylactic shock also will come under distributive shock only. Afterload will increase because of vasoconstriction. Tissue perfusion will be low. That is MVO2, mixed venous oxygen saturation will be low. Cardiogenic shock, preload increased. Pump function definitely low. Afterload increased. Tissue perfusion low. In distributive shock, the most important feature will be afterload will be extremely low. So pump function, that's why I told pump function can be low or normal. That's why clearly written, cardiac index will become low in late stages. In late stages, it can be low, but it can be normal also in early stages. It's quite variable. But here the most important finding is this low PCWP and high afterload and perfusion. And what about distributive shock? In distributive shock, the main important thing is this low systemic vascular resistance. Systemic vascular resistance. And because of that, the tissue perfusion will be actually high. That's a very, very important finding. This is very unique for septic shock or any distributive shock for that matters. Unique. And pump function, it's highly variable. You can write even increased in early stages, but later stages it will be suppressed, but it's highly variable. PCWP reduced. What about obstructive shock? If it's pulmonary RV type, there is obstruction to the blood that's flowing from right to left. So the left-sided flow will be less. So because of that, the pulmonary capillary wedge pressure will be low. And otherwise, cardiac index will be low, SVR will be high, and your mixed venous oxygen saturation will be low. Mechanical PCWP will be high. Otherwise, it's going to be the same. Only difference between mechanical and pulmonary RV type is the PCWP. In mechanical, because of compression of the heart from outside, definitely the chamber pressures will be high. That's why the pulmonary capillary wedge pressure is also high, which is nothing but an indirect measure of left atrial pressure. So as I said, Swan-Ganz is not routinely required to find out this data, but what is enough in modern practice is clinical features. With that itself, we can tell what is the type of shock going on. An hypolimic JVP will be low, extremities will be cold, fluid response definitely has LV function normal, which means in echo, if you see left ventricle, it will pump normally only, and initial treatment is going to be fluids plus or minus blood products. Depending on the situation, you can give blood products. And sometimes it can result in massive transfusion also. And what about cardiogenic shock? JVP will be high, extremities will be cold still, fluid responsive 100% no, LV function reduced. Initial treatment, inotropes predominantly. And what inotropes you choose depending on the, in exams, clinical features should be enough to diagnose. Mostly, yes. If you know the clinical features properly, it's enough to diagnose. Inotropes. Inotropes, what inotropes you're going to choose? Either noradrenaline or dopamine. Because in shock, you cannot use inotropes like dobutamine or milrinone or levosimendan because they are vasodilatory and they can cause problems. So noradrenaline will be the first choice in such situations. What about distributive shock? JP low, extremities will be warm. A very important point, that is because of peripheral pooling of blood. Fluid responsive, yes. LV function, LV function fairly normal, or even it can be increased in certain situations. Initial treatment depending on the cause. If you're thinking about sepsis, first treatment will be IV fluids, then antibiotics. An antibiotic should be given within 1 hour. And at least obtain before giving antibiotics, obtain at least 2 blood cultures prior. 2 sets of blood cultures should be obtained prior. Before giving antibiotics, please get 2 sets of blood culture. Initial treatment will be with IV fluids and antibiotics. As I told you, broad spectrum antibiotics should be given within 1 hour. And before giving antibiotics, at least get 2 blood cultures. Otherwise, if you give antibiotics and then take blood cultures, there is a risk that blood cultures will be negative. That's the reason why you have to collect blood cultures before giving antibiotics. And what about the obstructive shock? CEP will be high. Extremities will be cold and fluid responsive, variable. Some may respond, some may not respond. LV function normal because only RV will be dysfunctional if at all. Initial treatment will be treatment of the cause. Whatever the causes, you treat accordingly. If it's a tension pneumothorax, you're going to perform needle thoracostomy. If it's a tamponade, you're going to perform pericardiocentesis. If it's in a pulmonary embolism, you're going to thrombolysis. If it's a RVMI, then you're going to either go for a PCI or you can do thrombolysis. It's up to you. So that's how you can manage a patient with shock. Have you understood this? Yes or no? Okay. So as usual, this is something I used to give. I don't know the mnemonic for all these things, and it's up to you. You try to memorize whatever you want to do with this. So I'm just going to give the data, that's all. Okay, so one thing that I don't know what Zainab ma'am has given. I've just took it from the aims.edu website. So usually they tend to ask it in aims only, no? FMG, they have not asked even a single question. As far as I know. FMG, they have not asked even a single question so far. Only INACT tend to ask. That too in the recent last INACT, they stopped asking this. I don't think the last INACT contained this question. Generally, it happens in INACT. They tend to ask like 2-3 years, the same question over and over again in multiple different forms. And after that, it stops. They don't go to the topic ever. So this time, they didn't ask anything from the IV cannulas at all. And FMG, if I'm not wrong, seeing the previous year questions, I have not seen even a single question from this cannulas so far. So far, if you have studied this well, then you might expect that surprise. But if you are not very well prepared to answer these kind of questions, then your surprise may become a tragedy. Okay. Arjun is commenting for the 3rd time. What do you want, Arjun? Who are that people? You are the people or who's that people? I don't know. Okay, let us continue. See, if it's only once, I would have just ignored. You are commenting like for 3rd, 4th time. I don't know why. Why should comment for 3, 4 times? We're just going on, right? Okay, what do you expect me to say, Arjun? Okay, I mean, let Arjun, I'll get number from Arjun and I'll discuss with him in phone. Sorry, guys. Okay. Let us move on. So this is the tag, right? So that is thromboelastography tag. So thromboelastography is like kind of a test that's going to assess the entire coagulation function. Everyone knows that it's a test of global coagulation function, right? So it's a test of what? Global coagulation function. So you're going to assess the entire coagulation system in a nutshell. That is what we call as tech. And there are certain things you're going to look at. R time. R time means from the beginning to the 2 mm mark. The 2 mm mark is what we call as reaction time, and it is based on clotting factors. And that from 2 mm mark to 20 mm mark, from 2 mm mark to 20 mm mark, we have another time called as K time, or otherwise called as clot rate time, which is basically based on fibrinogen. This K time is dependent on fibrinogen. Another equivalent to that K time is the alpha angle. Nothing. The slope representation of the K time is the alpha angle. That's also K time and alpha angle both are same. And then we have the maximal amplitude. Maximal amplitude, which is dependent on the platelets. So that's the peak clot strength. The peak clot strength is what we call as maximal amplitude. And then from the maximal amplitude till the 30 minutes mark, we are going to see how much clot strength has reduced. That's what we call as LI30. So this is the peak clot strength, and this is the strength at 30 minutes. So there is some reduction in the clot strength, and that is the effect of fibrinolytic system. This LY30 is a measure of fibrinolytic system in the body. So accordingly, we can give blood products. If it's increased R time, treatment will be FFP because the problem here is coagulation factors. If it's increased K time or reduced alpha angle, the problem here is fibrinogen, so I'm going to give cryoprecipitate. If the problem is reduced maximal amplitude, then I'm going to give platelets. If the problem is going to be increased LY30, then I'm going to use tranexamic acid. That's all. Because here there is hyperfibrinolysis so that the clot strength will be reduced so that the patient will be bleeding more. So increase R time, FFP, increase K time, reduce alpha angle cryoprecipitate, reduce maximal amplitude platelets, increase LY30, give tranexamic acid. This is the final take-home message. That's it. Now cardiac arrest. Cardiac arrest is very simple. We have discussed it already. You know the paddle placements. I'm not going to go details. This is a device called as automated external defibrillator. I'm not going to talk about that as well. So how many times we have discussed? Whenever you encounter a collapse. So what are you going to do? When you encounter collapse, you want to leave this topic. That's an important topic, man. Okay. So whenever you encounter collapse, what are you going to do? You have to verify scene safety. Scene safety. And you're going to activate emergency medical services. Activate emergency medical services. Probably you call for help. That's all. So then, if everything is fine, check for responsiveness. Patient is responding or not. Okay. Responding or not. So if the patient is responding, just observe. No need to do anything. If the patient is not responding, then check the carotid pulse and breathing. Check the carotid pulse and breathing. If the patient is not having pulse and not breathing properly, now only you're going to start with CPR because this is what we call it as cardiac arrest. In other situations where the pulse is present, breathing may be there or not, that doesn't matter. If the pulse is present, no CPR is indicated. You have to just observe the patient. The situation where pulse is not there, breathing is also not there. In that situation only, I'm going to start with CPR. You know the thing about CPR, it is CAB. Chest compressions are the more important, then followed by airways, then finally breathing. You know the quality of chest compressions, right? It should be at least 100 to 120 per minute, not more, not less. It should be pressed by 2 to 2.5 inches or 5 to 6 centimeter, and it should be what? Like uninterrupted. Uninterrupted. It should never be interrupted at any cost. It should be uninterrupted. So breathing depends. Suppose if the patient is having only basic airway, then you can follow the routine 30:2 protocol for rescue breaths. If the patient is having advanced airway, then you cannot follow the basic 30:2 protocol. In that situation, you have to go for 10 breaths per minute. 10 breaths per minute. That's the number that you need to know. When is having only basic airway like oropharyngeal, nasopharyngeal airway, then 30:2. If the patient is having advanced airway like laryngeal mask airway or endotracheal tube, then your goal is to exactly deliver 10 breaths every single minute. That's the idea. So while you are continuing CPR, let us assume your AED comes to the scene. And once the AED comes, you're going to check the rhythm. Rhythm may be VTVF, which is a shockable rhythm, or pulseless electrical activity or asystole, which are basically non-shockable rhythms, right? If it's VTVF, I'm going to shock. There are two types of shock. One is monophasic shock, second is biphasic shock. Monophasic and biphasic. Monophasic energy required is 360 joules. Biphasic energy required is 120 to 200 joules. Any day, I always tell that biphasic is better compared to monophasic because energy required is less and the efficiency is also more. If it's PER or systole, continue CPR for 2 minutes and then check the rhythm again. And depending on whether the rhythm is shockable or non-shockable, you continue whatever algorithm you want. So after shocking also, same thing. You have to continue CPR for 2 minutes. You should not forget that. Even if you shock, the next step is to continue CPR for another 2 minutes and then you check the rhythm. So don't discontinue CPR at any cost, even after shocking. That's a very, very important take-home message. And there are a lot of drugs that we use in CPR, right? One is epinephrine, or we can call it as adrenaline. Epinephrine or adrenaline. What is the standard dose? 1 milligram IV, 1:10,000. Because we're giving IV, it should be 1:10,000 rule. And whether it's effective in shockable rhythms, yes. Non-shockable rhythms, yes. When you will give in shockable rhythms, generally after second shock. Generally, you are going to give adrenaline after second shock. After first shock, you will be busy in introducing IV line. Non-shockable rhythms, you can give immediately, ASAP, as soon as possible. There is no specific timing. And how frequently you repeat adrenaline? Every 3 to 5 minutes. Every alternative CPR cycles, you can keep repeating adrenaline. Then we have amiodarone and lignocaine. Previous guidelines said that amiodarone is better, but current guidelines clearly say that amiodarone and lignocaine are basically equal. These are also called as antiarrhythmic drugs. And the dose of amiodarone is 300 milligram. Dose of lignocaine is 1 to 1.5 milligram per kilogram. Obviously, it will be given as IV. And it can be used only for shockable rhythms after third shock. That too, you can use only after third shock. For non-shockable rhythms, amiodarone or lignocaine is not indicated. You can repeat once, but with half dose. You can repeat with half dose one more time. So for example, adrenaline 150, lignocaine will be 1.5 to 0.75 milligram per kilogram. That's all. Cardiac arrest is done. This is the most important things that you are doing in cardiac arrest. Then pulmonary infections. So pulmonary infections, three things, right? So one is they will ask only about CAP. So currently they are only talking about community acquired pneumonia. Other things they don't ask, or they might give an image like this, which is nothing but lung abscess. The first image is an example of a community acquired pneumonia where you're seeing air bronchogram. So this is a consolidated area and you can clearly notice the air bronchogram, right? So this is the area of consolidation. Whitish patch with air bronchogram that is so typical of a pneumonia, lobar pneumonia. So in lung abscess, what you're going to see is a thick walled cavity with air fluid levels. There will be a thick walled cavity with air fluid levels. I repeat, thick walled cavity with air fluid levels. That is very much suggestive of lung abscess. So how will you manage a community acquired pneumonia? So generally what we see is CCOP 65 score. The score is 0, then treat as outpatient. Score is 2, treat as inpatient, typically non-ICU setting. Score is 3 and above, treat as inpatient, but preferably in the ICU. If it's 3, 2, 5. If it's score of 1, then it depends. You can go for OP or IP management. It's up to you. Just 1 second. Somebody is asking most common etiology for abscess is anaerobes or not. Actually, answer is not. Most common etiology is not anaerobes. Anaerobes are a part of lung abscess. Usually, there will be polymicrobial infection. Whenever you talk about lung abscess, polymicrobial. So we cannot say which is the most common. So whenever you talk about polymicrobial, multiple organisms will be involved. And there is a high risk that anaerobes also will be there. And among the anaerobes, if you ask me the most common, people who have attended my lecture should be able to say, no, what anaerobe is likely to be the most common. Most common anaerobe. What is the most common anaerobe that is isolated from lung abscess? Have you ever heard of something called peptostreptococcus? Peptostreptococcus. Heard of this? This is the most common anaerobe usually seen in the setting of lung abscess. Among the anaerobes, that's the most common anaerobe. But lung abscess per se will be polymicrobial. Okay. So outpatient or inpatient. Score 1 can be treated as outpatient or inpatient. When you're going to treat as outpatient, whenever age is more than or equal to 65, which means if the score of 1 is obtained only because of the age, then guidelines say that you can treat as an outpatient. If the score of 1 is achieved not because of the age, if the age is less than 65 and still the score is 1, means better to treat as an inpatient. That's what the guidelines are recommending. So it depends on the age. That's all. And what about the curve 65 score per se? You all know, I'm not going to write one more time. Confusion. U stands for urea. There are 3 things in urea. Either blood urea nitrogen more than 7 millimoles per liter, or they may give blood urea nitrogen more than 19 milligrams per deciliter, or simply they can give urea more than 40 milligrams per deciliter. So either blood urea nitrogen or urea itself can be given in exam. And respiratory rate of more than or equal to 30 per minute. And B stands for BP, that is systolic BP less than or equal to 90, and or diastolic BP less than or equal to 60. And 65 means you all know, age more than or equal to 65, that carries 1 point. Right? Simple. So these are the components of the curve 65 score. Depending on that, you can decide. In case if you are deciding to treat as an outpatient because the score is 0, what are you going to do? Look at the risk factors. If the patient is not having risk factors, then you can give either azithromycin or doxycycline. Monotherapy is enough according to guidelines. The patient is having risk factors, or if you wanted to treat as an inpatient, then the regime must be either a beta-lactam with azidoxy combination, or you can use something called respiratory fluoroquinolones, which is nothing but levofloxacin or moxifloxacin. Any one of these drugs only should be used. Levofloxacin or moxifloxacin. The beta-lactam that you are choosing must be a BL-BLA, that is beta-lactam-beta-lactamase inhibitor like amoxicillin clavulanic acid or piperazillin tazobactam or ampicillin sulbactam. Or alternatively, you can choose third generation cephalosporin like cefotaxime, ceftriaxone. I will recommend 5 antibiotics in the beta-lactam group: amoxicillin clavulanic acid, piperazillin tazobactam, ampicillin sulbactam, cefotaxime, ceftriaxone. In exam, you will get one of that only when it comes to beta-lactam. Don't worry. If you want to treat as an ICU, here beta-lactam becomes a must. It's no longer an option. Beta-lactam is a must. Along with that, you give azithromycin, a macrolide, or a respiratory fluoroquinolone, which can be levofloxacin or moxifloxacin. So respiratory fluoroquinolone means we're talking about what? Levomoxy, respiratory fluoroquinolone. Here beta-lactam becomes a must. Here you cannot avoid beta-lactam. And especially if they mention that the patient is having penicillin allergy, then the beta-lactam of choice will be astronum, because astronum does not have any cross allergy with penicillin allergy patients. So if they specifically mention beta-lactam penicillin allergy, then the beta-lactam of choice will be astronum. Otherwise, the routine beta-lactams can be used, whichever I mentioned. In case if the patient is having community-acquired MRSA suspicion, what is the most important point here? Post-influenza pneumonia. Whenever patient is getting a pneumonia after a flu, that's likely to be a MRSA pneumonia. Here, additionally, you have to add vancomycin or linezolid. And because community-acquired MRSA produces an additional toxin called pantan-valentin leukocidin, it's better to add clindamycin to downregulate the toxin production. Okay, so that's another point that you need to know. And in case if they ask you how lung abscess will present, usually there will be history of low GCS. Low GCS like head injury, alcoholism, something will be there. And this would have resulted in aspiration, and that would have led to lung abscess. This is the usual mechanism of lung abscess. And clue in exam will be fever with foul smelling sputum. Fever will be there. Along with that, there will be severely foul smelling sputum. So that is because of anaerobic contamination. This foul smelling sputum is predominantly because of anaerobic contamination. Along with that, because it's an abscess, definitely you can expect fever to be there. And if they ask you treatment, you can use so many options are there. But in FMG exam, they will expect you to answer clindamycin. But apart from that, I don't know. You have so many options like ampicillin sulbactam, moxifloxacin, ceftriaxone with metronidazole combination, levofloxacin metronidazole combination, piptazo. Okay, so many meropenem, imipenem. So many options are there for treating lung abscess. But in exam, you can answer clindamycin if you want. So this one, everyone knows. This is an example of a fungal ball, otherwise called as aspergilloma. So what is fungal ball? There will be an old TB cavity. So this is an old TB cavity or a dead TB cavity. In that, you are going to see a ball of fungus. So this is the fungal ball. It's just aspergillus is infiltrating the old TB cavity. And yes, you are correct. If you are seeing a crescent shape shadow like that, that is what we called as monod sign. This is what called monod sign. So this is typical of a fungal ball. Only complication, massive hemoptysis. Otherwise, patient will be asymptomatic. Totally benign condition, asymptomatic. Only complication if they ask you, they can develop massive hemoptysis. For the treatment of choice is going to be surgery. Stabilize the patient and push for surgery, because there's only one option for treatment, that is surgery. Your antifungals won't enter your fungal ball. It's a dead TB cavity. Next is invasive pulmonary aspergillosis. Mostly, if you look at invasive pulmonary aspergillosis, patient will have history of severe immunosuppression, like neutropenia will be there, or neutrophil count will be less than 500, chemotherapy will be there, or patients will be a post-transplant patient, HIV/AIDS, heavily immunosuppressed patient for some reason, and they're going to present with lots and lots of symptoms like fever, hemoptysis, cough, shortness of breath. So many symptoms will be there. Okay, and in most of the cases, if you suspect invasive pulmonary aspergillosis, your serum galactomannan will be positive. These are investigations we do. Serum galactomannan will be positive, and serum 1,3 beta-D glucan will be positive. Serum galactomannan and serum 1,3-beta-D-glucan will be positive generally. And if you do imaging, in imaging, you're going to see two signs. One is called halo sign. Second is called as air crescent sign. Air crescent sign. You know what is halo sign, right? You'll have a consolidated area surrounded by ground glass appearance. Air crescent sign happens during recovery. So this is a typical air crescent sign where the neutrophils have started digging into the area that contains fungus. They destroy that area and produce a crescent-shaped air shadow called as air crescent sign. Treatment of choice, simple, it is voriconazole. In aspergillus, always go for voriconazole, one of the best drugs for aspergillus. Then we have allergic bronchopulmonary aspergillosis. ABPA, usually this happens in patients with history of cystic fibrosis or bronchial asthma. Either patient will have history of cystic fibrosis or patient will have bronchial asthma. Something will be there in the patient for sure. And it's a type 1 hypersensitivity reaction. So obviously, patient will be having high Ig and high eosinophils. Eosinophil count will be very high and Ig levels will be very high. In general, Ig levels will be more than 1000, very high Ig, because it's a type 1 hypersensitivity reaction. And how the patient will present? Cough and productive sputum. And in imaging, one of the characteristic finding is mucus plugs. You're going to see this kind of mucus plugs, which also produces that characteristic finger in glove appearance. Finger in glove appearance. And aspergillus is something that is known to produce central and proximal bronchiectasis. Even this is a very important word. Central and proximal bronchiectasis. Usually only cystic fibrosis and ABPA produces central and proximal bronchiectasis. Other conditions won't produce central proximal bronchiectasis. And what about the confirmatory investigation? We are going to do something called aspergillus skin prick test, which will be positive. And we have something called aspergillus specific immunoglobulin that will be positive in the blood as well. Aspergillus specific immunoglobulin means it could be IgG or IgE. Anything can be positive. Treatment, first line treatment is steroids, plus or minus. If you want, you can add antifungals also if the disease is severe. Itraconazole or voriconazole. But the first line treatment is always steroids because it's a hypersensitivity reaction. So history of bronchial asthma or cystic fibrosis coming with excessive sputum. And in imaging, you will see mucus plugs. Over time, they will develop central proximal bronchiectasis, very high Ig, very high eosinophils. Aspergillus related allergic test will be positive, like skin prick test, and aspergillus specific immunoglobulin will be positive. Treatment is steroids. Maybe if you want, you can add antifungals. That's it, done. Let us move on. Did you understand till now whatever I told you? Yes. Cool. Okay. Coming to the important casts and crystals in urine. On top, what cast is this? These are cellular casts. On top, you all have cellular casts. In the bottom, you are going to have acellular casts. Cellular casts, first, RBC cast always means glomerulonephritis. WBC cast always means pyelonephritis or acute interstitial nephritis. Either dealing with pyelonephritis or acute interstitial nephritis. This is epithelial cell cast, not very specific. Epithelial cell cast not very specific, just indicates tubular injury. Here is the hyaline cast, non-specific, homogeneous and glassy. Muddy brown cast, always suggestive of acute tubular necrosis. Here is fatty cast, suggestive of nephrotic syndrome. Nephrotic syndrome. And these fat globules will contain cholesterol esters. These fat globules will contain cholesterol esters, and this cholesterol esters is going to appear in polarized microscope as Maltese cross bodies. These fat globules contain cholesterol esters, and those cholesterol esters in polarized microscope will appear as these kind of Maltese cross bodies. And here's an example of broad waxy cars, indicative of CKD. That's all. Coming to some of the important crystals. Here's an example of the most common crystal in the world, that is calcium oxalate crystal. This is envelope-shaped bipyramidal dihydrate crystal. Here is a dumbbell-shaped monohydrate crystal. This is an example of calcium phosphate crystals, which appear in the form of asymmetric rods. And here's an example of uric acid crystal, which will be appearing more in rhomboid shape, which arranges to form rosettes. Here's an example of cystine crystals, which are hexagon in shape, one of the hardest crystals in nephrology. And here's an example of screw-wide crystals, or otherwise called as triple ammonium phosphate crystals, where the shape is coffin lid. Always screw-wide crystals means you're having infection. Infection with urease positive organisms like Proteus klebsiella or Ureaplasma urealyticum. Coming to certain drug-induced crystals. Here's an example of sulfur crystals, methotrexate crystals, which have a kind of fluffy appearance, wool-like appearance. These are characteristic indinavir crystals, which are needles arranged in rectangular plates that have a feathery appearance. Sulfur crystals, which tend to have shocks of wheat appearance. And finally, acyclovir crystals, which are needle-shaped. In fact, out of all, the most important is acyclovir-related crystals, which are typically needle-shaped. Now going to glomerulonephritis. We have discussed this approach time and again. So whenever you have a patient with glomerulonephritis, next step is to see immunofluorescence. If immunofluorescence is negative, I'm going to call it as post-immune type glomerulonephritis, type 3. This type 3 glomerulonephritis. Next step is to check for ANCA. As I told you so many times, if you have C ANCA, then you diagnose something else. If it's P ANCA, you diagnose something else. C ANCA means you're talking about anti-PR3 antibody. Here the diagnosis vaginous granulomatosis or granulomatosis with polyangiitis. If it's a P ANCA, the antibody that you're dealing with is anti-myeloperoxidase antibody. It can be either eosinophilic GPA, that is Chooks-Strauss syndrome, or you are dealing with microscopic polyangiitis. You know that vaginous granulomatosis patients will have ENT involvement and they're going to present with pulmonary renal syndrome. This is the typical feature of vaginous granulomatosis. If it's Chooks-Strauss syndrome, patients will have bronchial asthma and eosinophilia. Pulmonary renal syndrome can occur, but it's very, very rare. In Chooks-Strauss syndrome, you don't get it. In microscopic polyangiitis, patients usually present with pulmonary renal syndrome, but there will be no ENT involvement, no bronchial asthma, no eosinophilia, and if you do biopsy, you won't have any granulomas either. No granulomas in biopsy either. Okay, this is typical of microscopic polyangiitis. This is how you make a diagnosis. Remember, for eosinophilic granulomatous polyangiitis and granulomatous polyangiitis, because the name itself has granulomas, they tend to have granulomas in biopsy. But MPA is the only ANCA-associated vasculitis that doesn't have any granulomas in biopsy. In case if immunofluorescence is positive, you're going to see what is the type of immunofluorescence. If the type of immunofluorescence is granular, I'm going to think about immune complex type. If it's smooth and linear, I'm going to think about anti-GBM antibody. Smooth anti-GBM antibody will come under type 1. And in case if there is associated pulmonary renal syndrome, it is called as Goodpasture syndrome. Without pulmonary renal syndrome, it should be never called as Goodpasture. Only systemic forms of PRS. Systemic forms of anti-GBM antibody disease that involves lungs and the kidney together will be called as Goodpasture syndrome. So that is for smooth and linear. In case if it's granular, I told you, if it's immune complex type, that is type 2. So next step is to see C3. If C3 is low, then I'm going to diagnose either PSGN or primary MPGN, which is a very rare entity, or some secondary causes like lupus nephritis and cryoglobulinemia. If C3 levels are normal, I'm going to think about only IgA nephropathy or Henoch-Schwann purpura. IgA nephropathy and Henoch-Schwann purpura. You all know that IgA nephropathy and HSP can be differentiated based on only one thing, that it is kidney-limited disease, but HSP is a systemic disease, which means patients will have multiple findings like palpable purpura, arthralgia, and GA involvement. Everything will be there in HSP, but in IgA nephropathy, it's a true and pure kidney limited disease. It doesn't have any systemic involvement. That's one of the most important ways to differentiate between IgA nephropathy and HSP. But nevertheless, both of them will be having history of URI, and both of them in biopsy will be having mesangial IgA deposits. Mesangial IgA deposits. So that's the common feature between both of them. And what about PSGN? PSGN patients will have evidence of antecedent streptococcal infection. Like for example, ASO ADB titers will be elevated in PSGN. Nothing else is required. And if you look at PSGN and primary MPGN, they are per se renal limited disease. But SLE and cryo are systemic diseases. SLE and cryo systemic disease. In case if it's SLE, obviously you will have antibody positivity. And not only ANA, even anti-dsDNA will be positive. Because it's lupus nephritis. One of the antibody that correlates heavily with lupus nephritis is anti-dsDNA. If it's cryo, hepatitis C virus will be there, and rheumatoid factor will be positive, along with systemic involvement. So HCV is cryo, cryo is HCV. You all know that. So this is a very simplified and easy approach to glomerulonephritis. This is something that we have discussed so many times. If you are very clear about this approach, then you can answer any question in exam. Have you understood? A quick revision, no? Whatever you have discussed. Understood, right? Yeah. So just brushing whatever we have learned. So now coming to nephrotic syndrome. So I told you the first three will be called as podocytopathies. All three of them will have podocyte effacement fusion. Primary cases idiopathic. If they ask you for primary treatment of choice is always immunosuppression. That's the treatment of choice. So minimal chain disease patients will present with edema, proteinuria. Membranous nephropathy patients also will present with same edema, proteinuria. And FSGS patients also will present with edema and proteinuria. Then how will you differentiate? Yeah, proteinuria means here we are talking about nephrotic range proteinuria. How we are going to differentiate? MCD will have normal light microscopy. FSGS patients will have abnormal light microscopy in the form of what you're going to see is FSGS. That's all. Focal segmental glomerulosclerosis. Focal means less than 50% glomerulus. Segmental means in the involved glomerulus, only the part will be involved. Rest will not be involved. And here in membranous nephropathy, there will be thick base membrane, plus there will be a characteristic epimembranous spikes. The spikes are so characteristic of membranous nephropathy. What are the secondary causes? The electron microscopy will show effacement of foot process of podocytes here, but it's quite non-specific in MCD. Again, in FSGS, you will see non-specific electron microscopy only. You won't see much. There will be effacement and fusion of foot process of podocytes, which is kind of like non-specific finding only. And here you will see that characteristic spike and dome appearance. Spike and dome appearance. And what are the important secondary causes of MCD? When it comes to secondary cause of MCD is Hodgkin disease and drug-related causes NSAIDs. If it's a membranous nephropathy, if it's FSGS, what are the secondary causes? Three important H's. The drug also on H is that is heroin. Apart from that, we have three important H's like chronic hypertension, long-standing hypertension. Because of hyperfiltration, you get problems. Then HIV, okay, tend to produce. Then third H is heavy patients. Yeah, morbid obesity, heavy patients, morbid obesity. So hypertension, HIV, heavy, heroin. And apart from that, if you want to add, you can add bisphosphonates also. And interestingly, HIV, heroin, and bisphosphonates tend to produce a type of FSGS called as collapsing type of FSGS, which carries basically the worst prognosis. HIV, heroin, and bisphosphonates, all of them tend to produce collapsing type of FSGS. Membranous nephropathy, what are the secondary causes? We can divide into CTD, infections, solid organ tumors. CTD that commonly tend to produce membranous nephropathy is SLE. Infection commonly tend to produce is hepatitis B virus. In fact, for hepatitis B virus, if they ask you the most common glomerular involvement, what type? Answer is going to be membranous nephropathy. Solid organ tumors in the sense that any solid organ tumor for that matters. It could be lung, liver, breast, prostate, but what is more important is colon cancer. Usually they will target colorectal cancer. But apart from that, any solid organ tumors can produce membranous nephropathy. What are drug-related causes? Only D-penicillamine. Even though bisphosphonates can produce membranous type also, but it is predominantly D-penicillamine. That's the most important drug. MPGN, immune complex type. What is the immune complex type MPGN? These patients are going to, primary MPGN is very rare, and these patients are going to present with mixed nephritic and nephrotic presentation. They don't just have nephrotic, they tend to have mixed nephritic and nephrotic presentation together. And secondary causes, we can say variety of infections. In that, hepatitis C virus is important. Hepatitis B virus is also important. Then infected endocarditis is important. Yeah, CDD, same. CDD can produce, malignancy can produce. Same three. Same. But what infections? Yeah, V patient getting infected, that's called a shunt nephritis. Infected endocarditis can produce, and hepatitis C virus can produce. And CDD wise, the most important is SLE and cryo. Cryo can produce MPGN also. And malignancy means any malignancy literally. Hematological or solid organ tumor can produce MPGN also. Drug wise, there's no much drug wise. Here you will have thickening of base membrane plus splitting of base membrane will be there. So there will be kind of tram tracking appearance, or we can call it as double contoured base membrane. That's so characteristic. And here you will see subendothelial and intramembranous deposits. Okay, the deposits will be subendothelial and they will be intramembranous as well. Yes, that intramembranous deposits is the one that splits the membrane, base membrane into two, resulting in tram tracking. Nodular GS, only diabetes, amyloid. In the diabetes is the most important. No drug-related causes. And light microscopy will show nodular mesangial expansion. Nodular mesangial expansion. Abba, see, you want to ask me questions or you want to finish? You want me to finish? If you keep asking me questions, how will I finish, man? Okay, fine. So nodular mesangial expansion. Nodular mesangial expansion, you would have seen the images already. I've shown in the classes. Expansion due to extracellular matrix deposition. That is the one that's going to produce what? That characteristic nodular glomerulosclerosis-like appearance, which are also referred to as what? In DKD, we call it as Kimmel-Steele-Wilson lesions, KW lesions. And electron microscopy, you don't see anything. That's all. So these are the 5 important types of nephrotic syndrome. Coming to review of acute kidney injury. So acute kidney injury is actually quite simple, provided what is going to be asked in exam. First, definition is the most important. So any exam, they will expect you to know the definitions only. So if you look at the definition of AKI, first definition, creatinine elevated more than at least 0.3 milligrams per deciliter. Increase in creatinine by more than 0.3 milligrams per deciliter that occurs in the last 48 hours. Next, increase in serum creatinine by more than 1.5 times the baseline, and if it occurs within last 48 hours. And drop in urine output to value of less than 0.5 ml per kilogram per hour, and if it passes for more than 7 days. Sorry. This is less than 7 days, and this is more than 6 hours. Kilogram per hour, and if it passes for more than 6 hours. That is oliguria. So among these 3, if any one is there, we can call it as acute kidney injury. So what I'm trying to say, increase in serum creatinine by more than 0.3 milligrams per deciliter in the last 48 hours, increase in serum creatinine by more than 1.5 times from the baseline value in the last 7 days, or fall in urine output to value was less than 0.5 ml per kilogram per hour for more than 6 hours. So this is the exact definition of acute kidney injury. Anyone, if you there, you can call it as AKI. AKI can be divided into pre-renal, intrinsic renal, and post-renal. Post-renal is the easiest way to find out because I told you so many times it will be due to obstruction. So what is the finding that you will see in bladder neck obstruction? In bladder neck obstruction, the most important finding will be increased post-viral residual urine. In ureteral obstruction, the most important finding will be normal post-viral residual urine, but there will be bilateral hydroerythronephrosis. H1 will be there. Hydroerythronephrosis will be there. That's going to tell you that it is basically it's a bladder neck obstruction or a ureter level obstruction. Okay. And if you ask me the important cause of bladder neck obstruction, it is actually prostate issues like benign prostatic hyperplasia. If it's a ureter level obstruction, it can be due to stones or it can be due to some retroperitoneal lymph nodes enlarging, causing obstruction of the ureter, especially in conditions like cervix cancer. So in case if it's a bladder neck obstruction, treatment will be Foley's, or you can go for SPC, suprapubic catheterization. In case if it's a ureter level obstruction, the treatment will be URS with DJ stenting. You're going to introduce a ureteroscopy and put a double J stenting. That's typical treatment for ureteral obstruction. Yeah. So if they ask you investigation of choice, finding out post-renal AKA, it is imaging. So all you need is just an ultrasound or CT of the urinary tract. Ultrasound is the first investigation. CT is the best investigation. That's all. Often we do ultrasound as the first, CT the best. Now, what about prerenal AKI? Prerenal AKI is typically only due to what? Hypoperfusion. Nothing more. Predominantly due to hypoperfusion. It can be due to reduced effective arterial blood volume or altered perfusion. Altered perfusion in the sense it will be due to drugs like NSAIDs that affect afferent arteriole or ACE inhibitors and ARBs that affect afferent arteriole. Or it can be due to rarely large vessel involvement like renal artery stenosis. And the treatment of any prerenal AKI is optimizing hemodynamics. Optimizing renal blood flow and optimizing hemodynamics, which means you have to do something to maintain perfusion to the kidneys. That's all. In intrinsic renal AKI, it can be glomerular injury in the form of acute glomerular nephritis, interstitial injury in the form of acute interstitial nephritis, vascular in the form of thrombotic microangiopathy. Best example will be HUS-TTP complex. Okay, thrombotic microangiopathy, or it can be atherembolic disease. Atherembolic disease. Tubular cause means we are talking about acute tubular necrosis. If you look at the urinalysis in pre-renal, intrinsic renal, and post-renal, the pre-renal and post-renal AKI tend to produce only a bland urine. Pre-renal AKI will be having a bland urine, and post-renal AKI also tend to have a same bland urine. The only type of renal failure where your urine is going to have active sediments is intrinsic renal failure. Like for example, you all know that in acute glomerulonephritis, you're going to expect RBC cause. In acute interstitial nephritis, correct? You're going to expect something called as WBC cause. And in acute tubular necrosis, you're going to encounter something called as muddy brown cause. Muddy brown cause. Okay. So the urine is going to be active. So that's a very important difference. Urine will be usually bland in all the conditions except this intrinsic renal failure, where urine will be kind of active. It's going to show lots of sediments, crystals, cast. Yeah, cystocytes will be seen in peripheral smear, not in urine. Cystocytes will be seen in peripheral smear in TME. Thrombotic microangiopathy means you have to have cystocytes in the peripheral smear. That's it. And what are the indications for urgent dialysis? Urgent dialysis indications. We have mnemonic, right? AEIOU. Yeah. What does A stands for? Acidosis. E stands for electrolyte disturbances. I stands for intoxications. O stands for overload state. And U stands for uremic complications. So, in what acidosis? Most guidelines agree that if the pH is less than 7.1 to 7.2, plus if it's refractory. You have tried some treatment, but it's not working. You can go for dialysis. pH less than 7.1 is the cutoff for emergency dialysis, but it depends. Some guidelines, some authorities say that less than 7.2 also you can bring on dialysis. Electrolyte disturbance, most important is hyperkalemia. Whenever potassium is more than 6.5, or if it's rapidly rising, or if it's refractory. Okay, that's a very important sign of, very important indication for dialysis. The intoxication, we'll talk about that. Overload means, most important will be diuretic resistant pulmonary edema. Okay, diuretic resistant pulmonary edema, where the oxygen requirement is keeping on increasing. And if it's a uremic problem, two important things. One is uremic pericarditis, where the risk of tamponade is very high. And second is uremic encephalopathy. Uremic encephalopathy. Bleeding is not a very important indication in the recent past. You can write if you want, you can write uremic bleeding also, but this has not become that important. Okay. And what are the intoxications? What are the drugs that are dialysable? We talked about a mnemonic, right? Yeah, Bliss Med C. B stands for barbiturates, L stands for lithium, I stands for INH, S stands for salicylates, that is aspirin poisoning. T stands for theophylline, or its close competition, that is aminophylline, correct? M stands for methanol. E stands for ethylene glycol. D stands for Depakote, or that is valproate or dabigatran. Why dabigatran is important? Because this is the only anticoagulant that can be dialysed. Only anticoagulant that can be dialysed is dabigatran. And C stands for carbamazepine. Okay, so these are the drugs that are dialysable. And for a drug to be dialysable, we all know it should have a low volume of distribution, it should have low molecular weight, and it should have low plasma protein binding. And it should have low plasma protein binding. So these are the prerequisites for a drug to be dialysable. And what are the two important drugs that cannot be dialysed? For example, you need to know that digoxin cannot be dialysed, warfarin cannot be dialysed. Two important drugs. Digoxin cannot be dialysed, and warfarin also cannot be dialysed. Benzodiazepines, yes, it cannot be dialysed, but these two are very, very important. Digoxin, warfarin cannot be dialysed. Then we have this table to differentiate between pre-renal AKI and acute tubular necrosis, which is the form of intrinsic renal AKI. AKI flowchart and previous you want. Okay. Just hold on a bit. Hey guys, are you there? Yeah, sorry. Actually, I was not feeling well. No, that's the reason I'm taking like small breaks every now and then, 2 minutes. Sorry. Already took medicine, man, but something is wrong. Okay, let us carry on. Let us try and finish as much as possible now. So no, this difference we have seen already. So how to difference between prerenal AK and acute tubular necrosis? Prerenal AK we know is that hypoperfusion. So the tubular function by definition will be normal in prerenal AK. Whereas in acute tubular necrosis, the tubular function will be lost. We have discussed that already. So as such, if you look at the urine in prerenal AK, I told you it will be bland. But in intrinsic renal AK, like acute tubular necrosis, the urine will be active. In the sense, you're going to typically see the muddy brown cast. Muddy brown cast. Specific gravity definitely increased in prerenal AK because concentration will be good. It will be more than 1.020. Urine sodium will be less, FeNA will be less because there will be good solutary absorption. Even urea absorption will be good, so the urea fractional excision of urea will be less. Only the numbers you have to know, it will be less than 20, less than 1%, and less than 35% when it comes to fractional excision of urea. Urine osmolality will be very high, right, because of good concentration. So it will be usually more than 500. Urine creatinine to plasma creatinine ratio will be high. It will be more than 40 because of good tubular secretion of creatinine. Bun creatinine ratio also will increase. It will be more than 20. We know that. And in acute tubular necrosis, the urinary specific gravity will be low. It will be less than 1.010 because they cannot concentrate. And accordingly, urine osmolality also will be low because they cannot concentrate the urine. And urine sodium, FeNA, and urea will be high because they cannot absorb solutes. So urine sodium will be more than 40. FeNA will be more than 2% by definition. And fractionalization of urea will be more than 50% by definition. And urine creatinine to plasma creatinine ratio will be low because urine creatinine will become less, but plasma creatinine will keep increasing because they cannot secrete creatinine. So that will become less than 10. And bun creatinine ratio also will be less than 15. If you want to remember only one, remember only the bun creatinine ratio and FeNA. These two, at least you should never ever forget. And the third point you should not forget is the muddy brown cast. Remaining, it's up to you. You remember, forget, that's up to you. But these things, I don't think you can ever forget. Not possible. Coming to CKD and transplant, you know how to define CKD. CKD is defined as eGFR of less than 60 ml per minute per kilogram, ml per minute per 1.73 meters square body surface area for more than 3 months, or if the patient is having albuminuria for more than 3 months. So this is the exact definition of CKD. So the duration will be in months to years usually, and you have G staging and you have A staging separately as far as CKD is concerned. If you look at the G staging, there's a GFR staging 1, 2, 3, 4, 5. G1 means GFR will be normal, more than 90. G2 means 60 to 89. G3A means 55 to, sorry, 45 to 59. 3B means 30 to 44. 4 means 15 to 29. And 5 means less than 15. And what are the goals of therapy? You have to address the risk factors, and try to slow down the progression, like control diabetes, hypertension, and so on. Slow progression. In 2, you have to estimate progression, correct. In 3 and 3B, you have to treat the complications. Treatment of complications becomes very, very important because complications generally start around your stage 3 CKD only. In stage 4, you have to prepare the patient for renal replacement therapy, like creating AV fistula, counsel them and prepare for renal replacement therapy. And in stage 5, which is also called as end-stage kidney disease, you are going to initiate renal replacement therapy. I'm not saying initiate, consider initiation. You have to discuss with the patient and consider initiation of renal replacement therapy. And if possible, enroll them for kidney transplantation. Enroll them for kidney transplant. When it comes to urine albumin creatinine ratio, A1 means it's less than 30. A2 means 30 to 299. A3 means more than or equal to 300. So less than 30 means no or mild albuminuria. A2 means moderate albuminuria. A3 means severe albuminuria. Told you so many times, as the A staging keeps increasing, there is a high cardiovascular risk. At the same time, there will be rapid progression towards end-stage kidney disease. They're going to progress much more rapidly to ESKD. And you know that most common cause of death in CKD is always cardiovascular risk. Cardiovascular risk, MI and heart failure. Okay, that is the most important risk factor for death, most important reason for death in patients with CKD, CV death only. We have discussed so many times. And there are 3 special complications. We cannot discuss all the complications right now, but what could be potentially asked in exam? The 3 special complications. What are the 3 special complications? Number 1, anemia of chronic kidney disease. Usual reason is low erythropoietin. So if you want to treat anemia of chronic kidney disease, treatment is erythroid stimulating agents. ESA, right? You have to treat with erythroid stimulating agents. What are the erythroid stimulating agents? We have epoetin alpha. We have darbepoetin alpha. And we have pegylated methoxy epoetin beta. There are 3 compounds. Any one of them you can use. In that, epoetin alpha is the one that has maximum receptor selectivity. Maximum receptor selectivity. But the problem with epoetin alpha is it has a shorter T-half. To address that only, we have other long-acting molecules. But the problem is darbepoetin alpha and pegylated methoxyepoetin beta doesn't have that much of receptor selectivity. Before going into erythroid-stimulating agents, always one has to rule out iron deficiency because it is so common in CKD patients. How do you rule out iron deficiency? One is ferritin value less than 100. Second, ferritin 100 to 300 plus if the transferrin saturation is less than 20%. How will you calculate transferrin saturation? Iron by TABC. So if the ferritin is 100 to 300 plus if the transferrin saturation is less than 20%, in this condition, what you have to do? First, give IV iron. Then only you have to give erythroid stimulating agents. All formulations of IV iron are safe in patients with CKD. All formulations of IV iron are safe in patients with CKD. You can give iron sucrose, iron dextran, iron isomaltositase, ferric carboxymaltose, okay, ferumoxytol, whatever you want, you can give. All formulations are safe in CKD. So if they ask you the target hemoglobin in patients with CKD, it is 10 to 11.5 grams per deciliter. This is what Harrison has clearly recommended. 10 to 11.5 grams per deciliter. Second is CKD mineral bone disease, which was previously called as renal osteodystrophy. Renal osteodystrophy. The main problem in renal osteodystrophy is hypocalcemia, which in turn is due to low levels of 125 DHCC. And along with that, there will be hyperphosphatemia, which is going to produce FGF23, fibroblast growth factor 23, from the osteoblasts. Whenever phosphate increases, that will be sensed by the osteoblasts in the bone marrow, and they produce FGF23, and that will further reduce 125 DHCC by inhibiting 1-alpha hydroxylase enzyme. And this phosphate also indirectly helps in hypocalcemia by chelation. So calcium and phosphate will bind together, na? So it will further reduce the calcium. And this hypocalcemia is going to trigger PTH, and PTH is going to increase like anything. And this is secondary hyperparathyroidism. And this PTH is the reason for development of the bone problem. By activating the osteoclast, they're going to cause renal osteodystrophy. So how can you treat? You have to address 3 things. You have to take care of the phosphorus, calcium, PTH, all 3. So how can you take care of the calcium? You can give calcium and calcitriol supplements. Calcium and calcitriol supplements, that is vitamin D, active vitamin D, and you can give phosphorus binders like calcium acetate and cerebellum. You can give phosphorus binders like calcium acetate and cerebellum. In that, if you ask me which is better among the 2, it's always cerebellum. That is better because that's been shown to improve survival. Calcium acetate has not been shown to improve survival. And third, if still the PTH is refractory, if still the PTH output is refractory, you have to give a drug called as cinacalcet, which is a calcimemetic, and it sensitizes the calcium receptor in the parathyroid gland and fools thinking like, and it fools the gland by making it think like there is too much of calcium, thereby reducing the PTH output. So its main effect is to reduce the PTH release from the parathyroid glands. And ultimate salvage option will be total parathyroidectomy. This is the final salvage option, ultimate option, right? Another unique complication is calciphylaxis. This occurs in advanced kidney failure patients. Those who are on routine dialysis also it can occur. And this is how it looks like. And it's a very, very painful condition. There will be calcification of these end vessels. Because of this calcification of end vessels, there will be total necrosis of the skin in that area. So if you see this kind of condition, what you are going to do? First step is to stop all calcium and vitamin D supplements. Along with that, if the patient is on warfarin, immediately stop warfarin and give vitamin K for warfarin reversal. Stop and immediately give vitamin K. And you have to start alternative anticoagulation. The best alternative anticoagulation is apixaban. This could be an exam question. So what you have to start is apixaban. Apixaban is a very good anticoagulant in the setting of CKD and renal failure. At any degree of renal failure, if they ask you the best DOAC, apixaban. Apixaban is the best DOAC, then followed by rivaroxaban. But what we don't use in practice is edoxaban and dabigatran. Edox and dabigatran we don't use. Use either apixaban or rivaroxaban in patients with renal failure. So this is how you manage. Plus, I have to give supportive care also in the form of surgery if it's required. If it's infected, then we can give some antibiotic coverage. So it all depends on what is the condition of the patient, right? So supportive care. And remember, it's a very painful condition. I think that's one of the FMGE exam questions only. They ask like, this condition doesn't have pain, but this condition has pain. Okay. Now, important electrolytes. So as I told you, the most important electrolytes in exam will be hyponatremia and hyperkalemia. The approach to hyponatremia is important and treatment of hyperkalemia is important. So hyponatremia approach, we have discussed n number of times already. So whenever the patient is having hyponatremia, if they ask you next step is to look at the serum osmolality. If the serum osmolality is normal or if the serum osmolality is increased, it's very likely to be a false hyponatremia. It's not a true hyponatremia. These are basically false hyponatremia. In case the serum osmolality is normal, it is called as pseudo hyponatremia. These are called as pseudo hyponatremia, and the usual reason will be very high levels of proteins or very high levels of lipids. Very high levels of proteins can occur due to conditions like multiple myeloma, or very high levels of proteins can occur due to type 2 familial hyperlipidemia in homozygous form. So either too much LDL, too much protein can create an artifact in the machine, and that is what is going to manifest as hyponatremia. That's why it's called pseudo hyponatremia. In case if the serum osmolality is high, it must be due to some circulating osmol, and that is called as hyperosmolar hyponatremia. Hyperosmolar hyponatremia. Hyperosmolar hyponatremia. And what could be the reason? Either it could be mannitol, it could be due to mannitol, or it could be due to too much of glucose. Like in conditions where glucose will be very high, DKHHS, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome, or HONC, hyperosmolar non-ketotic coma. So these are the usual reasons. So if the serum osmolality is low, it is called as hyposmolar hyponatremia. That's a true hyponatremia. Then next step is to check the volume status. The volume state, if the patient is hypolimic, check for urine sodium, because the patient is hypolimic means I'm thinking about salt wasting. So I need to know where the salt is getting wasted from. If the urine sodium is more, then it must be renal salt wasting, which can be either due to Addison disease or it might be due to cerebral salt wasting syndrome, CSWS. In case if the urinary sodium is low, then it indicates extrarenal salt wasting, typically due to GI loss, like vomiting, diarrhea. In case if the patient is hypervolemic, then there is salt overload. The patient is having salt overload. That's why patient is hypervolemic. My question is to find out where this excessive salt is coming from. So if the urinary sodium is low, which means salt is getting absorbed from the urine only, that's why urinary sodium is low. This indicates RAS activated slate like cirrhosis, nephrotic syndrome, and heart failure. If the urinary sodium is high, then it's simple and straightforward. It is due to low GFR. Low GFR occurs in renal failure, AK and CKD, which means the primary problem here is low GFR. For that matters, the waste products are not getting filtered itself, and whatever is getting filtered is also lost in the urine because the tubular absorption is lost. So low GFR. This is the usual reason. And coming to patients who are having euvolemic hyponatremia. If pain is having euvolemic hyponatremia, you have to look at urine osmolality, because here looking at urine sodium doesn't make any sense because the patient is having no salt overload or no salt wasting. Salt wasting is also not there. Salt overload is also not there. Patient is clinically euvolemic, normal BP, normal JVP, no ascites, no effusion, no pidal edema. And it's very unlikely that urine sodium is going to be altered over a day. So urine osmolality will be a better marker here. The urine osmolality is more than 100 to 300. It indicates that the water is coming from urine only. Because if it's euvolemic hyponatremia, then there is dilution. So that water is more in the body. That's why patient is getting hyponatremia. So I need to know where that water is coming from. So it can be renal or external water gain. If it's renal water gain, the most important differential diagnosis is SAD. Other two important differential diagnoses will be myxedema, apart from SAD, and cortisol deficiency. Cortisol deficiency, not aldosterone or Addison. It's cortisol deficiency. And SAD is the most common cause of hyponatremia in hospitalized patients. I've told you so many times, it is the most common cause of hyponatremia in hospitalized patients. The urine sodium is less than 100, the urine osmolality is less than 100, means the urine is dilute, which means water is not coming from urine, it's coming from elsewhere. One DD is psychogenic polydipsia, second DD is low solute hyponatremia. If the patient is not taking enough solutes. Like for example, there are conditions like beer potamania, and we have a diet called as tea and toast diet. We have a type of diet called as what? Tea and toast diet. Tea and toast diet. So these are the classic examples of low solute hyponatremia. So now, having known the etiology of hyponatremia, how will you treat hyponatremia? Treatment is based on whether the patient is having severe symptoms or not. If the patient is having severe symptoms like coma and seizure, you are going to start with 3% hypertonic saline. Immediately, you have to start with 3% NaCl. Stuck. You have to start with 3% NaCl, right? So if the patient is not having severe symptoms, then what you're going to do, you're going to go for standard management of hyponatremia. Once you correct with 3% NaCl also, you're going to give standard management only. What is the dose of 3% NaCl? 100 plus 100 plus 100. So first you give 100, doesn't work, give another 100, then you give another 100. The total is 300. That's all. So standard treatment. So what do you mean by the standard treatment of hyponatremia? You all know that for hypovolemic hyponatremia, my 0.9% NaCl will be a better choice. Okay. Normal saline. For SADH and patients who are having high serum osmolality, fluid restriction is the first line treatment. Plus or minus, I can use Vaptans like tolvaptan in severe cases. For psychogenic polydipsia, my treatment will be fluid restriction. And for low solute hyponatremia, I have to give solutes. Give solutes like, for example, normal saline. Give solutes. Because this patient is not having enough solute power to pull the water out. So give solutes and remove that water out. If it's a hypervolemic hyponatremia, then fluid restriction will be the primary treatment. Along with that, if you want, you can use loop diuretics also. Okay. So these are the standard management of hyponatremia. And how much you should pull down. So in a single day, if it's an acute hyponatremia, in a single day, it should not exceed 8 to 10 milliequivalents per liter per day. If it's a chronic hyponatremia, it should not be more than 4 to 6 milliequivalents per liter per day. In case if you exceed, what is the risk? There is a high risk of a complication called as ODS, that is osmotic demolition syndrome, otherwise called as central pontine myelinolysis. The old name for osmotic demolition syndrome is central pontine myelinolysis. So what is the treatment? In case if you accidentally overcorrect, treatment will be 5% dextrose. Or you can say dextrose 5 water plus desmopressin. You can give desmopressin to re-lower the serum sodium. That's what you're planning to do actually. So give desmopressin and re-lower the serum sodium. One second. Re-lower the serum sodium. Okay. All right. Cool. Have you understood? Shall we move on? Yes or no? Okay, fine. Next, move on to hyperkalemia management. I told you in the entire world, if you want to know about hyperkalemia causes, very few causes are there for hyperkalemia. One is renal failure. Second is drugs. Rarely, there will be massive cell necrosis. Massive cell necrosis will be there. Massive cell necrosis means you're talking about tumor lysis syndrome and rhabdomyolysis. These are rare causes. Okay, not very common. But in the entire world, if they ask about hyperkalemia, these are the most important causes. These two are the most important causes. In the drugs also, most of the time it will be ACE inhibitor, ARB, ARNI, or potassium sparing diuretics, calcineurin inhibitors. So these are the usual reasons for hyperkalemia. In that ACE inhibitor, ARB, potassium sparing diuretics are very often used together in hypertension patients, and sometimes it can be used in heart failure patients. So that's why these are the usual culprits when it comes to drugs. That's why most of the times in exam, they won't ask about the causes of hyperkalemia because it will be right in front of your eyes. Easy. So what you need to find out is how will you treat. So usually the first treatment of any hyperkalemia is going to be calcium gluconate. We all know that. So that is to stabilize the membrane potential. It is to stabilize the membrane potential. Because hyperkalemia patients are at extremely high risk of developing arrhythmias. Okay, hyperkalemia patients are at extremely high risk of arrhythmias. First, you need to stabilize the patient, stabilize the membrane from developing arrhythmia. So that's the reason why we give calcium gluconate. And as expected, it's going to have only a transient effect, which means all you're going to get is some 30 to 60 minutes of time. That's all. You're only going to get some around 30 to 60 minutes of time. So you just buy some time. Before that, and before the 30 to 60 minutes, you need to do something to to lower the serum potassium. And you need to know that calcium gluconate has nothing to do with the serum potassium. It doesn't alter the serum potassium at all. So next step is to give drugs that reduce serum potassium immediately. Means these drugs are going to start acting within 50 to 30 minutes. So they're going to start acting immediately, right? But these drugs don't alter the total body potassium. They only reduce the serum potassium, but they don't alter the total body potassium, which means all these drugs are going to exhibit only transcellular shift of potassium. So what do you mean transcellular shift? They're going to move the potassium from ECF to ICF. They're only going to move the potassium from ECF to ICF. What are these drugs? Insulin, but we mix with dextrose to reduce the risk of hypoglycemia. Soda bicarbonate creates alkalotic environment that is conducive for moving the potassium from ECF to ICF, and beta-2 agonists like repeated salbutamol nebulizations. All of these drugs tend to start working within 15 to 30 minutes, and all of these drugs are going to have a total effect of approximately only 4 to 6 hours. So calcium gluconate only for 30 to 60 minutes. Insulin, soda bicarbonate, and salbutamol are going to work for 4 to 6, 2 to 6, 4 to 6 hours approximately. And there are 3 other compounds that can eliminate potassium from the body. They're going to reduce the total body potassium. One is potassium binding resins. In that, the commonly used potassium binding resin is SPS, that is sodium polystyrene sulfonate. And one complication of sodium polystyrene sulfonate that was asked in one of the NEET and one of the FMGE exam is colonic necrosis and perforation. SPS acts primarily on the colon and is a non-selective drug. So it can cause heavy damage to the colon and can even result in colonic necrosis and perforation. And other drugs, new drugs include patiromer and zirconium. Patiromer is also it's more selective drug. Zirconium is the most selective drug. It's also called as sodium zirconium cryosilicate. And how these drugs work? These drugs work by eliminating potassium in the GI tract. And loop diuretics also can be given like furosemide. They tend to eliminate potassium via the urine. So they tend to increase the urinary potassium. And loop diuretics are going to be particularly useful if the patient is having edema and volume overload state. And the last resort is hemodialysis, that is renal replacement therapy. By definition and on paper, it is the most fastest way or the most rapid way to eliminate potassium from the body. And it's indicated only if the patient is having refractory hyperkalemia or if the patient is having AKI and a potassium of more than 6.5. Any potassium is more than 6.5 in the setting of AKI is an indication for dialysis. If you have AKI, potassium more than 6.5, you can initiate dialysis according to most guidelines. Or the patient is having refractory hyperkalemia, not responding to conservative therapy also, you can manage with dialysis. So these are the options for hyperkalemia. With that, we can look at some of the important ECG changes in hyperkalemia and hypokalemia. So this is very commonly asked in exam. Look at this ECG. There are 3 changes that are going to encounter. One of the earliest changes in hyperkalemia is going to be flattening of the T wave. The T wave will be flattened. Along with that, there will be ST depression and there will be a prominent U wave. So just a triad of changes. Flat T, prominent U, and ST depression. So this is the typical triad of changes that you get in patients with hypokalemia. On top of that, the QT interval can be prolonged. Actually, it's not QT interval, but it's QU interval. We are confusing it as QT, but that's okay, whatever you call it. What is the triad of changes in hyperkalemia? In hyperkalemia, you're going to have tall T, then you're going to have absent P wave or widening of P wave will be there. Patients will be having wide QRS. Typical. So patient is going to have hyperkalemia, tall T waves, and I don't think I'm seeing any P here, absent P, and I can also notice the widening of the QRS. So tall T wave, absent P wave, widening of the QRS. And slowly this wide QRS will become what? Sine wave pattern. And this sine wave also stops and it will result in diastolic. Okay, diastolic cardiac arrest. Yeah, that is diastolic cardiac arrest. And at any stage, they can trigger arrhythmias also. And remember, hyperkalemia produces short QT. Hypercalcemia also produces short QT. Hyperkalemia also produces short QT only. So this is a typical triad of changes that you see in patients with hyperkalemia. Shall we move on? Yes? Okay. This is an easy topic, right? Rheumatoid arthritis. And the entire rheumatology is actually quite easy only. It's not a very difficult topic at all. We'll finish it off very fast. Okay. You know the important genetic risk factor for rheumatoid arthritis is what? HLA-DR4. Environmental risk factor, only two. Smoking, silicosis. In that, smoking is the most important. Articular manifestations, most common joints involved, MCP, wrist, and PIP. MCP, PIP, and wrist joint. Typical involvement, this is called as rheumatoid distribution. In that, the most common will be MCP joint. And the most common large joint involved in rheumatoid arthritis is knee joint. That's the most common large joint. And what are the joints that are spared in rheumatoid arthritis? One is going to be the DIP joint, and second is going to be the thoracolumbar spine. DIP and the thoracolumbar spine. Okay, which also tells you that the only spine that is involved in rheumatoid arthritis is cervical spine. Extraarticular manifestation, most common subcutaneous nodules, which are basically painless. Apart from that, eye manifestation is Zika, that is dry eyes, otherwise called as secondary Sjogren syndrome. What doesn't occur in rheumatoid arthritis is anterior uveitis. Anterior uveitis does not occur in rheumatoid arthritis. Next, cardiac involvement, most common pericarditis. That's the most common. Apart from that, they can also cause restrictive cardiomyopathy and conduction blocks. And also remember that rheumatoid arthritis is common in females who are in the 30 to 60 years age group. And the most common cause of death in rheumatoid arthritis is cardiovascular risk. Most common cause of death in rheumatoid arthritis is cardiovascular risk. Correct. Pericarditis. And lung involvement, most common, pleuritis. Pleuritis is the most common, but don't forget about the effusion. Effusion in rheumatoid arthritis that tend to have extremely low glucose. I'm repeating 2-3 times because that's been asked so many times that effusion in patients with rheumatoid arthritis tend to have extremely low glucose. And rheumatoid arthritis patients also tend to have ILD, interstitial lung disease, and the most common picture is going to be UIP, that is usual interstitial pneumonia. All the other CDDs produce NSIP, only RA produces UIP pattern. And ultimately, hematological manifestation, most common if they ask you answer is definitely anemia. Anemia, but don't forget the Felty syndrome. So what is Felty syndrome? Triad of RA, neutropenia, and massive splenomegaly. Massive splenomegaly. So this is what we call as Felty syndrome. And what is the most common cancer in rheumatoid arthritis? B cell type of NHL. The most common subtype will be DLBCL. B cell type of NHL, and very commonly it will be DLBCL type. Serology, yes, rheumatoid factor may be positive and anti-CCP may be positive, but specificity wise, anti-CP is the one that's going to be most specific, more than 95% specificity. Acute flare treatment, always steroids, no doubt. If you look at the DMARDs, there are 3 types of DMARDs. Conventional synthetic DMARDs, conventional synthetic DMARDs, then we have biological DMARDs, then we have targeted synthetic DMARDs. Three groups. Commonly in India, what we start with is conventional synthetic DMARDs, where you have methotrexate, HCQ, and sulfasalazine, the classic three drugs which come under the triple therapy. Alternative to methotrexate will be leflunomide. And if they ask you the backbone of RA treatment, answer is methotrexate. Methotrexate is considered to be the backbone of rheumatoid arthritis management. And what are the drugs that are not currently used commonly? Azathioprine, D-penicillamine, and gold. These are drugs that we don't commonly use for rheumatoid arthritis. Okay, it's not that effective. Plus, they are having a lot of side effects also. The commonly used drugs are methotrexate or leflunomide, along with that HCQ and sulfasalazine. Biological DMARDs can be divided into anti-TNF group, which are the best treatment for rheumatoid arthritis. Anti-TNF alpha group. Yeah, we have 5 drugs, right? Infliximab, etanercept, adalimumab, golimumab, certolizumab. So infliximab, etanercept, adalimumab, golimumab, certolizumab. They ask you which of the drug is available in pegylated formulation. Answer is certolizumab. That's available in pegylated formulation. And we have the non-anti-TNF group. So what are the non-anti-TNF group? We have anti-CD20, that is rituximab. We have anti-IL-6 receptor, that is tocilizumab, and sarilumab, that is anti-IL-6 receptor group. Then we have CTLA4 fusion called as abatacept, and we have anti-IL-1 called as anakinra and canakinumab. So rituximab is anti-CD20, tocilizumab and sarilumab are anti-IL-6 receptor, abatacept is CTLA4 fusion, and anakinra and canakinumab are anti-IL-1 drugs. So these are the non-anti-TNF group. But the first line is always anti-TNF group. And you all know the important side effect of anti-TNF drugs, that is drug-induced lupus erythematosus. They slightly increase the risk of lymphoma. And more importantly, anti-TNF drugs can increase the risk of reactivation of hepatitis B virus and TB. That's the reason you have to always check for latent TB with the help of a test called interferon gamma release assay before giving anti-TNF drugs. And you also have to do serological markers for hepatitis B virus before starting anti-TNF. Because if marker is positive, then you have to treat those things simultaneously. You have to treat latent TB and you have to treat hepatitis B also, because risk of reactivation of hepatitis B and latent TB is very, very high in the setting of anti-TNF. And anti-TNF also increase the risk of lymphomas, and anti-TNF drugs also increase the risk of drug-induced lupus erythematosus. Target synthetic DMARDs are called as JAK inhibitors. They block the JAK receptors, not so popular drugs. We have tofacitinib, we have baricitinib, and we have upadacitinib. And in that, the most selective drug is going to be upadacitinib because it's selective for JAK1. But baricitinib is not very selective. It is going to inhibit JAK1 and JAK2. Tofacitinib is the most, non-selective, that's going to inhibit JAK1, 2, 3. Yeah, tofacitinib, JAK1, 2, 3. Baricitinib, JAK1, 2. And upadacitinib, only JAK1. It's the most selective, upadacitinib. And plus, you just add on all the deformities. That's Swan neck deformity, boat neck deformity, and Z deformity, commonly asked in FMGE exams. Then, if you look at rheumatoid arthritis, one important feature which is specific for rheumatoid arthritis is erosions. Whenever you have erosions, it is quite specific for rheumatoid arthritis. You don't see in any other disease. That's why erosions are quite important. You have to look for the X-ray. And if they ask you the most common deformity in rheumatoid arthritis, it is ulnar deviation of fingers. Ulnar deviation of fingers is the most common deformity in rheumatoid arthritis. And erosions are specific for rheumatoid arthritis. That's why it's called as erosive arthritis. Understood or not? Shall we move on? Yes, right? Okay. Now, Coming to seronegative arthritis. So why it's called seronegative arthritis? Because patients will be RF negative, anti-CCP negative, and they will be ANA negative as well. All three will be negative. That's why it's called seronegative spondyloarthropathy. What are the common features? We have something called inflammatory back pain, IBP, inflammatory back pain. So where the pain will increase, the pain and stiffness in the back will be more in the morning, but as the patient starts exercising, the pain will come down. That's why inflammatory back pain. And patients tend to develop anteriovitis. Anteriovitis, which is the most common extra-articular manifestation of seronegative arthritis. Okay. If they ask you what is the most common extra-articular manifestation of seronegative arthritis, answer is going to be anteriovitis. Yes, some of them are actually HLA-B27 associated. Some of them. Not all. Some of them are HLA-B27 associated, but maximum association is with ankylosing spondylitis. Maximum is associated with ankylosing spondylitis. But the association percentage will be variable depending on the type of seronegative arthritis. But anteriovitis is the most common extra-articular manifestation of rheumatoid arthritis, seronegative arthritis. Then they can develop dactylitis that can lead to sausage-shaped digit inflammation of one entire finger. They can lead to enthesitis. Enthesitis. So what is enthesitis? Enthesitis is inflammation of the insertion points of ligaments and tendons, especially the Achilles tendon area will be typically involved. Then patients can have spinal peripheral arthritis. Peripheral arthritis. What is the special feature of this peripheral arthritis? Usually it involves the lower limb more than the upper limb. And there will be asymmetric and oligoarticular. Typical feature, asymmetric and oligoarticular. Oligoarticular means only 2 to 4 joints will be involved and they'll be asymmetric. And lower limb will be involved more than the upper limb, which is exactly opposite to rheumatoid arthritis. Rheumatoid arthritis is symmetric, polyarticular, and upper limb will be more than lower limb. And the most common joint involved here is the knee joint. But in rheumatoid arthritis, it is small joint, that is MCP joint. And apart from peripheral arthritis, patients can develop spinal rigidity and that can progress to the characteristic bamboo spine. So these are the typical features of your seronegative spondyloarthropathy. In that ankylosing spondylitis, what will clinch you the diagnosis in exam? Bilateral, symmetric, and more importantly, before that, ankylosing spondylitis is an axial arthritis compared to peripheral arthritis, and the axial involvement is 100%. Without axial involvement, you cannot get ankylosing spondylitis. And psoriatic arthritis, peripheral more than axial. The same thing applies to everything else. This is also peripheral more than axial. This is also peripheral arthritis more than axial arthritis. And ankylosing spondylitis patients, the key word will be bilateral, symmetric, sacroiliitis. The keyword will be bilateral symmetric sacroiliitis. There is no other disease that produces this problem. Bilateral symmetric sacroiliitis. And even in imaging, you're going to have symmetric marginal syndesmophytes. Syndesmophytes. Symmetric and marginal syndesmophytes. This point again very important. Symmetric and marginal syndesmophytes. What are the other problems? Ankylosing spondylitis patients will have aortitis and this will lead to aortic regurgitation. In fact, the most common valvular heart disease in patients with ankylosing spondylitis is aortic regurgitation, and that is because of aortitis. And patients can have bilateral upper lobe fibrosis. Bilateral upper lobe fibrosis, and this can lead to reduced chest expansion. This can lead to reduced chest expansion, and that is because of bilateral upper lobe fibrosis. And skin lesions, you don't get with ankylosing spondylitis. You don't get any skin lesion. Imaging findings, I'm not going to talk much because we have discussed already. There's a lot of signs like shiny corner sign. We have bamboo sign, yeah, Romanus lesions, bamboo sign, dagger sign. So many signs are there. So I'm not going to talk about that. Symmetric syndesmophytes are the most important. And in psoriatic arthritis, what you will see? You will see the psoriatic skin and nail changes. Psoriatic skin and nail changes. What will be the most important clue? Most important clue will be DIP involvement. Most important clue will be DIP involvement. DIP involvement, which is not going to be the case in rheumatoid arthritis, right? And psoriatic arthritis is going to present more uniquely. Most of the psoriatic spondyloarthropathies are common in males less than 40 years of age. Psoriatic arthritis alone is common in, it's not having any male-female ratio. Male-female involvement is same in psoriatic arthritis. But otherwise, most of the psoriatic spondyloarthropathies will be common in males less than 40 years. Psoriatic arthritis, males equal to females. And interestingly, 20% of psoriatic arthritis can present without skin and nail changes. You may not have skin and nail changes, but still patient will have psoriatic arthritis. And the clue will be DIP involvement, strongest clue. Imaging, the typical pencil cup, DIP deformity. What about reactive arthritis? They're going to present with a classic triad. So what is the classic triad? Can't pee, can't see, and can't climb a tree. What is can't pee? You're going to have urethritis. What is can't see? Conjunctivitis. And can't climb a tree is because of arthritis. So this is a typical triad. Urethritis, conjunctivitis, and arthritis. They ask you which joint is most commonly involved in arthritis. It's the knee joint. Yeah, it's also called as Retus syndrome. Knee joint is the most common joint involved in arthritis. And most of them will have history of gastrointestinal infection or a genitourinary infection. Very important point. Because it's a reaction to some underlying infection. So they are going to have gastrointestinal and genitourinary infection. The most common gastrointestinal infection is going to be Shigella. The most common genitourinary infection is going to be chlamydia. Chlamydia. And so we can boldly say that this urethritis is a non-gonococcal urethritis. That urethritis is a non-gonococcal urethritis. And here you will have asymmetric non-marginal syndesmophytes. That's why this point is important. They're going to have asymmetric non-marginal syndesmophytes. In ankylosing spondylitis, you had symmetric marginal syndesmophytes. Here, asymmetric non-marginal syndesmophytes. Because here also, spine involvement is quite common. Oh, I've written here. Okay. I should have written in the X-ray. Okay. Asymmetric non-marginal syndesmophytes. And what will you get in skin changes? Skin changes, two classic skin lesions, right? One is succinate balanitis and second is keratoderma blennergicum. So I'm not going to write fully because to save time. So succinate balanitis and keratoderma blennergicum. Succinate balanitis is inflammation of the glans penis. Keratoderma blennergicum are nothing but hyperpigmented macular eruptions in the palms and soles. That is keratoderma blennergicum. Enteropathic arthritis will produce erythema nodosum and pyoderma gangrenosum, typical of IBD, because enteropathic arthritis tend to occur with a history of inflammatory bowel disease. Only in those people you get this enteropathic arthritis. And there is no specific radiological finding of note in enteropathic arthritis. And apart from that, we have type 1 and type 2 peripheral arthritis. Axial arthritis is ankylosing spondylitis like, and peripheral arthritis can be type 1 and type 2 peripheral arthritis. Type 1 is asymmetric, oligoarticular, and type 2 is symmetric and polyarticular. That's type 2 peripheral arthritis. And they may ask you which is going to correlate with underlying bowel activity. The type 1 is the only thing that's going to correlate with the underlying bowel disease, which means if the bowel disease flares up, the type 1 also flares up. If the bowel disease becomes quiescent, type 1 also becomes quiescent. But this axial arthritis and type 2 symmetric polyarthritis will not correlate with underlying bowel activity. They're going to behave as if they are separate diseases, and they may require separate treatment also. It's not like if you control the bowel disease, you will control the type 2 and AS-like picture. Okay? What's the treatment? If they ask you for inflammatory back pain, treatment of choice will be NSAIDs. NSAIDs is excellent for patients who are presenting with inflammatory back pain. On the other hand, you can use some disease-modifying drugs. The best disease-modifying drug will be anti-TNF drugs. Anti-TNF drugs, and we have a combined anti-IL-12 23 inhibitor. The drug is called as ustekinumab. Did you discuss about ustekinumab? Do you remember? Combined anti-IL-12 IL-23 inhibitor, ustekinumab. And can you tell me what is the anti-IL-23 inhibitor? Important anti-IL, yeah, that is guselkumab. What is anti-IL-17 receptor inhibitor? What is that drug? Secukinumab. 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 So these are the drugs that are approved for use in seronegative spondyloarthritis. And for psoriatic arthritis alone, there is a drug called apremilast. It's a phosphodiesterase 4 inhibitor that's been approved for psoriatic arthritis. The drug is called as apremilast. So anti-TNF, ustekinumab, guselkumab, secukinumab, apremilast. That's it. For seronegative spondyloarthritis. Yeah, correct. Let us move on. Crystal arthropathies. So we have two crystal arthropathies, right? Gout and pseudogout. Actually, they will ask about how to treat acute gout and acute gout. That's what is more important. I mean, how acute gout is going to present? Acute gout is going to present. Acute gout is going to present with monoarthritis. That too, first attack, always monoarthritis. That is first MTP joint. Grade 2. First MTP joint, grade 2 involvement. That's classic. And you have to know that serum uric acid is normal in approximately 30 to 40% of the cases of acute gout. Serum uric acid will be normal in 30 to 40% case of acute gout. Investigation of choice is going to be joint aspiration. That is synovial fluid analysis. Investigation of choice will be joint aspiration. That is synovial fluid analysis. We are going to see the classic crystals. So where are those crystals? Here are the crystals. So this is what is seen in polarized microscope in the synovial fluid analysis. We are going to see needle-shaped crystals. Needle-shaped crystals which are negatively birefringent. Negatively birefringent. These are needle-shaped crystals which are negatively birefringent, which indicates they are monosodium urate crystals. And in musculoskeletal ultrasound, you see this kind of sign. This sign is called as double contour sign. The sign is called as double contour sign. That is what I'm going to see in musculoskeletal ultrasound. And how will you treat acute gout? Treatment, always baseline treatment will be NSAIDs, but we will add colchicine. Colchicine, even though it's given optional, but we wanted to add colchicine to reduce the rates of relapse. Generally, we give NSAID for 1 to 2 weeks and colchicine for 3 to 6 months. And then slowly we will withdraw. That's all. Alternative to NSAIDs, same like pericarditis. You're going to use corticosteroids or you're going to use anti-IL-1 therapy like anakinra or canakinumab. Anyone can be tried. And in chronic gout, what you will see? In chronic gout, one of the important X-ray signs that are commonly asked in exam is Martel G sign. This is called as Martel G sign, characteristic rat bite erosions, or we can say erosions with overhanging edges. And in pseudogout, what is the typical imaging finding? You're going to see something called chondrocalcinosis. Chondrocalcinosis, calcification of the articular cartilage. And pseudogout typically affects the knee joint, very common in elderly patients, and the most common joint is the knee joint. And if you do joint aspiration, you can see the polarized microscope. In the polarized microscope, you're going to see rhomboid shape, weak positive birefringence of these crystals will be seen. There will be rhomboid and there will be weakly positive birefringence. Rhomboid shape, weakly positive birefringence. Not positive, weakly positive birefringence. Understood? Shall we move on? Yes. So what are the important antibodies in systemic lupus erythematosus? So mostly they'll ask antibodies only, no? In exam. They won't ask anything. And in pathology, maybe you can study the immunofluorescence. That immunofluorescence pattern alone you can study in pathology if you want. So what are the antibodies? First, we are talking about ANA. That is anti-nuclear antibody. So that's the most sensitive. Sensitivity in SL is more than 98 to 99%, but it's very poorly specific. Its specificity is very poor, and any value of more than 1:80 can be considered significant. And what about anti-dsDNA? Sensitivity of anti-dsDNA is only 30 to 50%. The remaining 50%, 50 to 70% may not have anti-dsDNA, but it's quite specific. It's quite specific for SLE. Yeah. And it's going to correlate with lupus nephritis and vasculitis. It's going to correlate with lupus nephritis and vasculitis. And then we have anti-histone antibodies, which is seen approximately in 50 to 70% patients with SLE, 50 to 70% patients in SLE, and it's going to correlate with mild arthritis and serositis. Mild arthritis and serositis. Yeah, mild arthritis. And what about anti-ROLA? They are originally Sjogren syndrome antibodies. They're called as SSA and SSB. They're called as what? SSA and SSB. In SLE, they're going to correlate with so many manifestations like photosensitivity, subacute cutaneous lupus erythematosus called as SCLE, subacute cutaneous lupus erythematosus called as SCLE, and they're going to correlate with myositis, and they're also going to correlate with something called myocarditis. Then what else? They're also going to correlate with NMO spectrum disease, that's correct. And more importantly, they're also going to correlate with something called as neonatal lupus. I told you so many times that neonatal lupus is the most common cause of congenital complete heart block. Neonatal lupus is the most common cause of congenital complete heart block. Yeah, so these are the correlations. And what about, and one more thing about anti-RO is they reduce the risk of lupus nephritis. That's the only good thing with anti-RO. Reduce the risk of lupus nephritis. So what about anti-UNRNP? Correlates with mixed connective tissue disease, 100%. Anti-ribosomal P correlates with psychiatric manifestations in lupus. Even though this is not completely correct, but Harrison still mentions this. Psychiatric manifestations like psychosis and depression. Anti-ribosomal P antibodies are quite specific for lupus. Okay, it's quite specific for SLE. What about APLA? We have 3 APLA antibodies, right? So one APLA antibody is like anti-cardiolipin antibody, IgN, IgM. Then we have anti-beta-2 glycoprotein 1 antibody. Then we have lupus anticoagulant. Lupus anticoagulant. This lupus anticoagulant we all know is going to present with increased partial thromboplastin time. Purity will be increased, which will not correct with mixing studies. If you do 50-50 mixing and all, it will not correct. But it will correct. It will correct with addition of excess phospholipids. Because these are anti-phospholipid antibodies, if you add more phospholipids, the PTT will correct. But if you add normal plasma, that is called mixing study, it will not correct. So these statements are very, very important for exams. And how to assess lupus anticoagulant? Using a test called as DRVVT. DRVVT. That's called dilute Russell Viper venom test. This is the usual test that they use in labs to find out the activity of lupus anticoagulant. That's called dilute Russell Viper venom test. And what is the mnemonic? Clot. C stands for clotting. Uniquely, these antibodies produce both arterial and venous thrombosis. And L stands for libido. O stands for obstetric complications, that is recurrent pregnancy loss. And T stands for thrombocytopenia. Okay, these are the clot manifestations that you see with anti-phospholipid antibodies. And what are the other antibodies? We have anti-Smith antibody, by default the most specific, correct? Most specific. Sensitivity is like 10 to 20% only, 10 to 30%, but on paper, this is the most specific anti-Smith antibody, the most specific on paper. Okay, all the antibodies is over. And what is the most important therapy in SLE? We can say backbone of SLE treatment. Backbone of rheumatoid arthritis treatment is methotrexate. What is the backbone of SLE therapy? HCQ, correct. HCQ is the backbone, very important. At any stage, we will keep giving HCQ. We will not stop HCQ in the SLE patients. We never stop. MTX is the backbone of rheumatoid arthritis therapy. In basic therapy. And we have a disease called DILE, right? Drug-induced lupus erythematosus. What are the important pointers about drug-induced lupus erythematosus? Number one, the drugs you know, SHIP group of drugs. We have discussed about the SHIP MD. So S stands for sulfa groups, sulfa drugs. H stands for hydrolazine. I stands for isoniazid. Pre stands for procainamide. And don't forget that I stands for infliximab also. It's not only INH, it's infliximab also. That means it includes anti-TNF as well. So sulfasalazine, sulfa drugs, hydrolazine, INH infliximab, procainamide, correct. M stands for minocycline, and D stands for what? D-penicillamine. And M you can include methyl dopa also. Correct. We have discussed that all those things. So this is the SHIP-MD group of drugs that causes drug-induced lupus erythematosus. And what will be the patient's presentation? They will only present with mild arthritis and serositis. And what will be the serological picture? ANA will be usually positive. ANA will be positive and anti-histone will be positive as well. But anti-dsDNA will be negative. Anti-dsDNA will be negative. So this is a typical profile. ANA positive, anti-histone positive, and anti-dsDNA being negative. Number 4, There will be absolutely no neurological involvement and lupus nephritis. Kidney involvement and neuro involvement will not be seen. Number 5, treatment will be to stop the offending drug. And this will lead to complete resolution of symptoms. And that's in fact the gold standard for diagnosis, complete resolution. Stop drug, complete resolution. And fourth point is very important. There will be no neurological involvement and lupus nephritis. In the sense like no neurological and kidney involvement whatsoever. That's typical of drug-induced lupus. Okay, antibodies are over. Next we have scleroderma. We are very limited only. After scleroderma, we have a little bit of myositis and we have a little bit of, I think, what to say, vasculitis, and that's it. Rheumatology is also done. 56, no, 45. 45 slides are left. You want break now? Okay, you can go for break and come back. I'll start from where we left. We have very little only. Don't need to worry about that. Anti-Smith is the most specific. dsDNA is not. Anti-Smith is the most specific. dsDNA, yes, it's specific, but it's not the most specific on paper. Class will decide as it goes, man. It won't be till 2 a.m. I think we are going faster only today, no? We'll come back by 6:15. Yeah, 6:15 anyway. The another session is starting. So we have to start with a new session. So 6:15 we can do. Okay. Take care. See you. Bye.